Hello everyone, good morning. Am I clearly visible, audible? Hello, hello everyone. Hello Kanish. Hello Osama. If I'm clearly visible and audible, can you write down in the chat box? I can see your chat. If everything is good to go, we will start. I'm good. Hello, good morning. I think I'm clearly visible, audible. The visibility, audibility is not an issue. You can see my slides also, right? So a very, very good morning to all of you. So I hope you all are doing good and I'm also doing very good. And today we all are gathered here to cover our topic. We continue the oncology series. So we have already started this series last month and we have already covered few tumors. So in this oncology series, basically I'm going to cover the important tumors of human body. So in the last series, we have already covered the breast cancer. We have already covered the tumors of the CNS. All those who have missed can watch. It's available on the YouTube on the same YouTube channel. Here today in this series, in this episode, I am going to cover very interesting tumors. Actually, I will be covering four things today. First, I will start with the thyroid tumors. I will cover everything about that. After that, it is related to Mann syndrome. So correspondingly, simultaneously, we will cover the Mann syndrome also. After that, the most important one, the most deadly tumor, we are going to lung tumor. And in the end, we will see the tumors of the kidney. So we are going to cover all these in the next 3-4 hours, whatever. And you people are going to stay. Right now, please, topics are very important. So most of the students know my way of teaching. First, we will related to topics, complete theory, and then we will solve the MCQs, which are already asked in the previous year question in the exam, right? So it will be very interesting. Keep on interacting. If you have any doubt, you can ask me. So there are many questions from the oncology comes in various competitive exams, especially if I'm talking about. So in FMG also you get many. Now oncology is not only pathology part of use. Here I'm giving an overview. And oncology will be there in the surgery also, pathology also, in medicine also. So in multiple subjects there is a overlap. So here I'm trying to cover the maximum portion of most of the tumors, most importantly, the important tumors. So after that, we have one more episode in I'm going to cover entire in which I will cover all leukemia one shot. But today we are going to cover these. Okay, my audio is good or it is lagging behind? Someone is saying the audio is not good. The audio, video, everything is good. Just a second. Audio is lagging. Let me fix. I guess it will be good now. I guess. Let's continue. Still, if you find any problem, kindly let me know. So let's continue with the first tumors out of the four. Let me start with the thyroid tumors. Let's start with thyroid tumors. Okay. So in the thyroid tumors, let me start with the thyroid tumors. We know thyroid is a gland present in the neck. We know in the thyroid gland there are two lobes. The right lobe, the left lobe, the two lobes are connected with each other with the isthmus. Right, now what are the cells present in the thyroid? In the thyroid we are having two type of cells, follicular cells and parafollicular cells. So let me highlight the follicular and parafollicular cells for you so that you will have a better understanding of the oncology portion. Can you see these are the follicles? The follicles are lined by follicular cells. These are the follicles which are lined by follicular cells. These all are follicular cells lining the follicles. And let me show you the parafollicular cells also. Parafollicular cells are present intermittently between the follicles. These all blue cells are parafollicular cells. Can you see? So we have seen the follicular cells and parafollicular cells. Okay. Follicular cells secrete the thyroid hormone T3 and T4. Follicular cells secrete T3 and T4. And parafollicular cells secrete calcitonin. It secretes a hormone that is calcitonin. Because when I will teach you the tumors, I will teach you out of the four tumors of the thyroid, which of them are arising from follicular cells and which of them are arising from parafollicular cells. So you must have a basic understanding that there are two types of cells in the thyroid, follicular and parafollicular. This gland is made up of two types of cells. Inside this gland we have many follicles. These are small follicles which are lined by follicular cells, and intermittently we are having small parafollicular cells which secrete the corresponding hormones. Follicular secrete T3, T4 and parafollicular secrete calcitonin. Okay, so let me come on the tumors directly. So there are four types of thyroid malignancies. First learn the names. What are the 4 types of thyroid malignancies? Papillary thyroid carcinoma, follicular thyroid carcinoma, medullary thyroid carcinoma and anaplastic thyroid carcinoma. Papillary, follicular, medullary and anaplastic. So these are the 4 types of malignancies which occur in the thyroid gland. So basically you have to understand all the important points including gross and microscopic features of the 4 type of malignancy. Are you people with me? Can we continue? So keep interacting. If you have any doubt, please ask. So can we continue with the 4 type one by one? So there are papillary thyroid carcinoma, follicular thyroid carcinoma, medullary thyroid carcinoma and anaplastic. Okay. So you see the percentage wise, the prevalence wise, papillary are the most common. 75% of the tumors are papillary. Follicular are second most common. You can see maybe it is 10 to 20%. The remaining 2 are very less. I mean medullary is only 5 and the rarest is the anaplastic. So you usually get question which is the most common. This is papillary. Which is the rarest one? The rarest one is the anaplastic. You learn in the sequence only. This is first, second, third, fourth. Right. Now I will read this table for you in the end. Now currently I am not reading. We have seen the 4. Let me tell you the details of all 4. Then we will learn this table in the end. So we have papillary carcinoma, follicular, medullary, anaplastic in this sequence. We have already seen their frequency, their prevalence, their frequency, which is most common, which is least common. Papillary occurs in all ages. Okay, anaplastic occurs only in old age, and the remaining 2, follicular and papillary, usually occur in middle age. So age is always a clue. Your question start, there is a female, most of them, they all are more common in females. Female more than male. Only medullary is equal in male and female. It's a very important MCQ, repeated in many exams. So which of them is equal in male and female? Say medullary. In medullary, the male is equal to female. And the prevalence in male and female, the frequency is same. But in remaining all, the female is 3 times more common affected. In papillary, in follicular, female is 2.5 times more commonly affected. And in anaplastic, the female is 1.5 times more commonly affected. Don't learn how many times, but learn in the remaining 3, female is more commonly affected than male. In the remaining 3, I mean papillary, follicular and anaplastic. But in medullary, the female and male are equally affected. Since medullary is going opposite of its family, it's very important question on the medullary. You got my point? Shall I repeat? Mr. Abhishek, you are asking. So shall I repeat? So I told you 4 type of thyroid tumor: papillary, follicular, medullary, anaplastic. My first request to learn the sequence. Don't change the sequence. You can make some mnemonic, but don't change the sequence. Now I am saying that in medullary, female is equal to male. The prevalence, so it is equal in frequency in male and female. But in the remaining 3, what I am saying in the remaining 3? In the remaining 3, females are more commonly affected in males. In all remaining 3. That is my point. So you have question on this, repeated question on this. Okay. So please learn male is to female, and please learn the age also. The papillary occur in all age, anaplastic occur in old age, and the remaining 2 occurs in the middle age. So we have seen the frequency, age and male-female frequency. Okay. Now we will start them one by one and we will have a look on this table again in the hand. Okay. Let's start with the first one. First one, papillary carcinoma. Among the 4, papillary carcinoma is the most common type. It is the most common type. And I told you here female preponderance. The females are 3 times more commonly affected than males. Okay. It occurs in all age, but usually in 20 to 40 years. And most common risk factor is radiation exposure in the neck. For example, someone is having lymphoma and the lymphoadenopathy in the neck. To treat the lymphoma, we have to give radiation in the neck. But that radiation can be a risk factor for the papillary carcinoma of the thyroid. You got my point? So radiation is a risk factor. Please learn. Radiation is always a risk factor. Okay. It is having excellent prognosis. It is least malignant among the all 4. Among the all 4, this is the best one. I mean best one having the excellent prognosis. And it's spread by lymphatic route. So please learn all the points. I will tell you corresponding points of all 4. So what we have learned, papillary, say ma'am, it's most common. It is the best prognosis, excellent prognosis. It's spread by lymphatic route, very late spread. And what is the risk factor? Risk factor is radiation exposure. Okay. And females are more commonly affected. We already know. Age is 20 to 40 years. We already know. So please learn all these points. Now tell me the mutation which occurs. For example, this is the neck. Inside the neck, this is the thyroid gland. In the thyroid gland, these are the cells of the thyroid, the follicular cells of the thyroid. Now when radiation are falling on this, when the radiation is falling on this, it will cause mutation inside the cells. The cell will convert to oncogenic. The cell will become immortal, and it will proliferate like anything. It will keep on dividing like anything. It will convert into a cancer cell. But what is the mutation taking place inside these cells? Name the mutation. Name the mutation. I am talking about the mutation taking place inside the follicular cells. Okay. So there are two type of mutation, either RET gene, the mutation in the RET gene, or anti-RK gene. Learn the name of the gene. RET gene or anti-RK gene. So either of the gene get mutated and it will proliferate. It will do dividing, non-stop dividing, and it will lead to a formation of papillary cancer. Got my point? Learn the name of the two genes, you get questions on that. Now coming on the gross appearance. Can you see the gross appearance? Can you see the thyroid? This is the thyroid gland, one of the lobe of the thyroid having the cancer. I can appreciate the margins of the cancer. These are the margins of the cancer I can see. So it is grayish white, hard, and I can see the papillary. You know what is papillary? I am teaching you papillary. So these are the papillary projections. The papillary projections means finger-like projection. So in the entire cancer, I am getting papillary projection, finger-like projections. Can you see? The finger-like projections are seen. So these are the papillary projections which are seen. Got it? So these are the papillary projections. You can see it here. The papillary projections are there. These are papillary projections. So grossly it is there. Microscopically, you have to learn three important findings, ultra important findings. First, tell me the pattern. Now, not only this microscopy, whenever we talk about the microscopy of anything in pathology, there is a peculiar way we describe the microscopy. The first thing, you have to tell me the arrangement of the cells. Tell me the arrangement of the cells, how the cells are arranged. Are they in sheets? Are they in lobules? Are they in papillae? Number one. Number two, describe the tumor cell after that. You have to describe particular tumor cell. So in the tumor cell, describe the size of the cell, whether the size of the cell is large, intermediate, small. Then describe the cytoplasm, eosinophilic, basophilic, granular. Then describe the nucleus. Nucleus is central, eccentric. Does it contain nucleoli? Is it eosinophilic? Is it compact? Is it hyperchromatic? Is it vesicular? So describe. This is how we describe a tumor cell. Okay. And after that, any particular specific unique findings are there. You have to describe that. So there is a peculiar way of description in microscopy. You got my point? So most of the students have trouble in microscopy. You got my point? Most of the students feel like how to describe a microscopy. Just suppose this picture is in front of you and you don't know anything about that. It's okay. It's okay if you don't know. Start saying the sequence. First tell me the arrangement. Can you see the tumor cells? These all are the tumor cells. These all. And I'm marking with red color. So first say the arrangement. You will say, ma'am, the arrangement is finger-like. So the arrangement is papilla. The arrangement is papilla. Now I will zoom this image to highlight one of the tumor cell. I want to describe the tumor cell. So first learn the arrangement is papillary. So multiple papilla are there. Let me draw the papilla. So this is a papilla, this is a papilla. So I am drawing the papilla. So papilla are lying on what? The papilla are lying on fibrovascular core. Now what do you mean by fibrovascular core? What do you mean by? So name itself indicate. Fibro means fibrosis. Vascular means blood vessel. Fibrovascular core. So you see I have drawn this fibrosis with the blood vessels. This is all fibrovascular core on which the papilla are lying. So papilla lie on fibrovascular core. Read this. The papilla are lying on fibrovascular core or stalk. So you can appreciate in this diagram also, can you appreciate the fibrovascular core? I want you to appreciate these blood vessels and the background pink color fibrosis. So this is all fibrovascular core you can appreciate on which multiple papillas are there. See people, yes, got it. Do you have any doubt? You got it? So can we continue? Okay, so this is the pattern. Now describe the tumor cell. Very important. Describe the tumor cell. Now let me zoom the tumor cell. Let me zoom all these tumor cells, zoom out. So can you see these tumor cells? So nucleus is important. Inside the nucleus, I will tell you three important findings. Three important findings. Can you see the nucleus? Now let me highlight the nucleus. Let me draw two type of nucleus in front of you. Okay, this is a cell, this is a cell. Now see this nucleus. Okay, and see this nucleus. See this. What is the difference between them? What is the difference between them? You will say here the nucleus is hyperchromatic. It is filled completely. It's compact. And here the nucleus is vesicular. This is known as vesicular, means empty from inside. It is empty from inside. So here in papillary carcinoma, we have this type of nucleus. Since it is empty from inside, this nucleus is known as ground glass appearance. It is known as ground glass appearance because it is empty, or it is known as optically clear. Optically clear, one and the same thing. Either you say optically clear nucleus, or you say ground glass, or you say orphan any eye nuclei. What is orphan Annie? Who is Annie? Annie is a cartoon character like the Mickey Mouse, है ना? In the same way, Annie is a cartoon character. She is orphan Annie. Orphan Annie. It's a cartoon character, you may be knowing. Okay. See the eyes of this Annie. The eyes of this Annie are empty. Can you see the eyes? The eyes are empty. So the nucleus is also empty. So this nucleus is compared with orphan Annie. You got my point? It's a very important question. Please learn that. So the nucleus in the papillary carcinoma, learn the three names. Either say orphan eye appearance, orphan any eye appearance, orphan any eye appearance, number one, or you say optically clear, or you say ground glass appearance. Ground glass appearance, one and the same thing. So either you say this or this or this. We are describing the nucleus. So read the three terms. Or either you say orphan any eye, you got it, or you say ground glass, you got it, or you say optically clear, you got it. So we are talking about the nucleus, the empty nucleus. If you don't got it, you can write the word empty. The nucleus is empty from inside. Not only this, two more things are important in the nucleus. So let me more zoom out to show you two more things inside that. See, you can see the papillae. Appreciate the papillae. I do not want to highlight the papillae. I want to highlight the nucleus of the cell. So let me highlight the cell. These are the tumor cells. I'm not interested even in cell. I'm interested in the nucleus of the cell. See the nucleus inside the cell. If you can see the nucleus, can you see these nucleus? This nucleus, this nucleus. If you see it closely, inside the nucleus you can see the groove. Let me draw it. So this is a cell. Let me draw. This is the nucleus inside which the grooving is like that. Have you seen the coffee bean? The nucleus is looking like a coffee bean. It is known as grooving. Grooves are present in the nucleus. Okay, number two. Okay, and sometimes inclusion bodies are also present. This is known as inclusion bodies. Inclusion bodies are present in the nucleus. Okay, so grooving, I can appreciate grooving at many places. If you see it closely, then only you will appreciate. See this nucleus, highlight the line inside the nucleus. See this nucleus, highlight the grooving. So many nucleus are showing the grooving. Let me more zoom it out. Can you see the arrows? Look at the arrows. The cell, the nucleus highlighted by the arrow. See this nucleus? This one I'm marking with red color. I want to highlight the grooving here. Okay, again I want to highlight the grooving. Okay, here I can see the inclusion body, a circular inclusion body inside this nucleus. So nucleus have grooving and inclusion body. How many of you got it? Okay, and sometime last and the third thing, psammoma calcifications are also present. What do you mean by psammoma? The P is silent. The psammoma calcification is the calcification in concentric spheres. See in this diagram. Can you see this one? Let me highlight this one. Can you see this blue color? What is this? Appreciate it. The blue color, concentric sphere. This is calcification. So calcifications are common. So psammoma body is the calcification at various places randomly, and it is in concentric spheres. Concentric. It is known as psammoma bodies, laminated in appearance. So tell me the features of the papillary carcinoma. Papillary carcinoma is done. What we have learned? Papillary carcinoma of the thyroid. So tell me three things. Number one, tell me the introduction, important points. Tell me the gross appearance and tell me the microscopy. Who will help me in writing, please? Introduction, gross and microscopy. In the introduction, write down it is the most common among the 4 thyroid cancer. Number one, it is having excellent prognosis. It is having best prognosis. Okay, it's spread by lymphatic route. Okay, and the risk factor is the radiation. The radiation is the risk factor. We have learned these important points in the introduction. In the gross, we have learned only one word. Papilla can be seen. It is grayish white, well circumscribed, and we can see the grossly papilla. Microscopically also we have seen 3 points. Number one, arrangement. Number two, tumor cells, and number three, some specific finding. So tell me the arrangement. What is the arrangement, people? What is the arrangement? Say arrangement is papilla. Don't say only papilla. Say papilla over fibrovascular core. Papilla over fibrovascular, lying over fibrovascular core. Describe tumor cells, describe the nucleus, 3 findings in the nucleus. Nucleus is optically clear. Optically clear, known as orphan any eye nuclei, or also known as ground glass nucleus. In the nucleus, grooves are there. In the nucleus, inclusion bodies are there. So we have seen that as the nucleus. And specific findings is calcification. Not calcification, it is in concentric rings. है ना? The concentric ring calcification is known as Samoma body. Samoma body is something unique there. है ना? So learn these features. You get many questions on this. This is papillary carcinoma. Likewise, we have to understand 3 more. Got it? Very good. Very good. Yes, you all are right. So that is the thing. Okay. Now coming on the next one, the second tumor. The second tumor is the follicular thyroid carcinoma. We are done with the papillary. Can I come on the second one? The second one is the follicular thyroid carcinoma. This is the second most common. What was the prevalence frequency there? It was 75%. This is nearly 10 to 20%. So secondly most common. This is also more common in female, but it is common in middle-aged female, 40 to 50 years. Okay. The risk factor there, kya tha risk factor there? What was the risk factor there? The risk factor there was radiation to the gland. Here the risk factor is iodine deficiency, long-standing goiter, the risk factor. And there the root was lymphatic. Here the root is hematogenous. Got it? So we have studied 2 till now, papillary and follicular. What we have learned? This is most common, this is second most common. Okay, here the percentage is 75, here it's 10 to 20%. Here the risk factor we have is radiation to the neck, here the risk factor is iodine deficiency. Okay, both of them, female are more commonly affected in male, there is no difference in that. But this one is in all ages. But this one specifically occur 40 to 50 years, the middle age female. So these, and yeah, the route of the spread. This one spread by lymphatic route, this one spread by hematogenous route. Okay, so please understand these findings, you have to learn that. Now grossly, the gross is not important here. Cut surface don't show papilla here. It shows hemorrhages, necrosis and cyst formation. Can you see the hemorrhage? Hemorrhage, necrotic areas are there. Microscopically, this is the slide. Please learn, this is the slide. Hello? So say the same thing. First tell me the arrangement, then describe individual cell, and then tell me the specific finding. In the entire pathology, I will not change, I will say in the sequence only. In the entire pathology. Tell me the arrangement. What is the arrangement? Is it papilla? No. It is follicles. Small follicular cells. The tumor cells are arranged in the follicles. The tumor cells are arranged. So say the arrangement is follicular. There the arrangement was papillary. Here the tumor cells are arranged in follicular pattern. Small follicles, various size. Some are small, some are large. Various size follicles are there. Okay. Various size follicles we can see. Now describe each cell. Now describe the nucleus. Can you see the cell? Inside the cell I can see the dot. The blue dots are the nucleus. They are hyperchromatic. In contrast, वहाँ का nucleus कैसा था? So the nucleus in the papillary carcinoma is like this, and the nucleus in the follicular carcinoma is like this. You can make out the difference. So this nucleus is optically clear, orphan any eye, ground glass appearance, and this nucleus is hyperchromatic. Okay, so please understand the nucleus is entirely different. So highlight the word hyperchromatic nucleus. Okay, what was the special finding there? Special finding there was Samoma body. Here we don't have Samoma body. Here we have vascular and capsular invasion. The capsular invasion. Can you see the tumor? Okay. Inside the tumor, can you tell me what is the structure? Let me highlight and ask you. What is the structure? Can you make out this pink color fibers? This pink color fibers. What is the structure? What is the structure? This structure is capsule of the thyroid gland. In the thyroid gland, we have a capsule. So can you see, let me show you. These all are the tumor cells. Okay. These all are the tumor cells. They are invading in the capsule, and after invading, it is going through and through to the capsule. This is known as capsular invasion. You can see the capsule is invaded. The capsule is invaded. Say yes if you got it. I am trying very hard to explain you. The capsular invasion is a hallmark here. It invades the capsule of the gland. You can appreciate. Now in this diagram, first appreciate the capsule. Where is the capsule? See the pink fibers. In the pink fibers, make it out where is the tumor. This is the tumor cells. It is infiltrating inside the capsule and going on the other side. So capsular invasion is very common, number one. And where is the blood vessel in the entire scene, in the entire slide? I guess you all can make out this is a blood vessel. Can you make out the blood vessel? The tumor cells are going. Can you appreciate this is a blood vessel? Now please appreciate the blue color tumor cells inside it. You can see the red is the blood. This is the RBC. But what is this? What is this side? This is all tumor cells gone inside the blood vessel. So in this slide, I can see two invasion. The capsular invasion, let me highlight. So this is the capsular invasion. Appreciate the blue color caps, I mean the pink fibers. So the tumor cells are going inside that, and appreciate the blood vessel. This is a blood vessel inside which I can see these all are the tumor cells. So capsular invasion and vascular invasion. Learn the two invasion, that is a hallmark here. Say yes, people, say yes. So what three things, है ना? We have learned one more thing, then we will compare, है ना? There is a special type of follicular carcinoma which is known as Hurdle cell or oncocytic carcinoma. So first learn Hurdle cell carcinoma, also known as oncocytic carcinoma. This is a special type of follicular. This is not a special type of papillary. This is a special variant of follicular. It's a question. Nearly 50% of the follicular cells are Hurdle cell only, है ना? So it occurs in females, है ना? Here the difference is that it is aggressive one. Normal follicular having good prognosis, but this is having aggressive one. And see, this is the histology. You can see this is the microscopy. What you can see? You can see the tumor cells are there here also. यहाँ पे भी है tumor cell. But you can see, ma'am, the cytoplasm is very pink here. Normally the cytoplasm was not that pink. Here in Hurdle cell, the cytoplasm is too eosinophilic. Pink cytoplasm matlab eosinophilic. The cytoplasm is too eosinophilic and granular. And I can see the cells are also very large. The cells are large. No, cells are not very large here. The cytoplasm is not eosinophilic, not granular. Here I can see the cytoplasm is granular, eosinophilic, and the cells are large. These are known as Hurdle cell. So what we have learned, can we revise till now? Out of the 4, the 2 are done. Papillary carcinoma of the thyroid is done and follicular is done. So can you tell me the microscopic features of both of them? I told you this is most common, this is second most common. This spread by lymphatic, this spread by hematogenous. Both of them are common in females. The risk factor here is radiation, the risk factor here is iodine deficiency. Iodine deficiency, that is goiter. After that we have seen gross, here papilla are there, and here necrosis, hemorrhage is there. Now coming on the microscopy, most important is microscopy, you have to compare. Tell me the arrangement, tell me the cell peculiarity, and tell me the special property. So what is the arrangement? You will see, ma'am, here arrangement is papilla over fibrovascular core, and here they are arranged in follicles. Okay, circle follicles. Here the cells में nucleus में खास बातें हैं. The nucleus is orphan eye, optically clear, ground glass. Inside the nucleus, grooving is there, inclusion body is there. Here nucleus is hyperchromatic. It's hyperchromatic, just opposite of that. Special finding, here we have psammoma bodies. Here we don't have psammoma bodies. Here we have 2 invasion. Which 2 invasion, people? Say, ma'am, capsular invasion and vascular invasion. I have shown you in the image also very clearly. And we have a special variant here. We don't have any variant here. But here we have a special variant which is known as Hurdle cell. Hurdle cell carcinoma is a variant of follicular carcinoma in which the cytoplasm is more pink and granular, and it is aggressive one. So I tried very hard to explain you the 2 types till now. So any question come, whether the question is on the general properties or gross or any microscopy or image based question, you can crack it. You can definitely crack it. So can I come on the third one? Everyone give me a thumbs up first. Everyone, those who are live, can I go on the next one? You are getting it? Yes, Hurdle cell is in follicular misty. So Hurdle cell is a special variant of the follicular, not papillary, in which the cells are relatively bigger in size. The cells are relatively bigger in size. The cytoplasm is pink. The cytoplasm is granular. You can see the pink cytoplasm and granular cytoplasm. That's it. This is the difference, and it is more aggressive. Okay. Can we go on the third one? The third one is the medullary type. Coming on the third one. The third one is the medullary type. There is a special thing. I am going to teach you 4 now. Papillary we are done. Follicular we are done. Currently I have started medullary, and last I will teach you anaplastic. So out of the 4, only medullary arises from parafollicular cell. The remaining 3 arises from follicular cell. I have told you before starting the chapter itself, I told you there are 2 types of cells in the thyroid gland. Follicular and parafollicular, if you remember. Right? So this one, can you see the follicular and parafollicular? See the diagram? See, these all are follicular cells which are lining the follicle. These all are follicular cells. So from follicular cells, the remaining 3 malignancies arise. Papillary also arise from here. Follicular also arise from here, and anaplastic also will arise from here. But can you see the parafollicular cell? Where are the parafollicular cells? The intermittent cell. These all cells. These all are parafollicular. From here the medullary is arising from here. So medullary is the only carcinoma which arises from parafollicular or C cell. So as I told you, the follicular cells secrete thyroid hormone. So remaining 3 malignancy will have hyperthyroidism. Because thyroid hormone will increase, they have the malignancy of the follicular cell. But in medullary, calcitonin will increase. In the blood, there will be more calcitonin. Because medullary arises from the parafollicular cell which secrete calcitonin. So calcitonin is the hallmark. So whenever you get a MCQ, a big clinical picture, there is a 40-year female presented with a neck swelling, some blah 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 history, and you will get the blood calcitonin levels are raised. The blood calcitonin levels. So you always think about the medullary. It's a very big clue for your medullary carcinoma. It can spread via both lymphatic and blood. So I told you papillary spread by lymphatic. I told you follicular spread by hematogenous, and now I am telling you medullary spread by both. So you will have a comparative analysis. In the end, I am going to give you a table, but first understand, okay? So please learn the spread is via both, okay? Now medullary is of two types. What are the two types? Say sporadic and familial. No other one is of two types, but this one is of two types. Sporadic occurs because of mutation, so 80% of the cases is sporadic only, but 20% occurs in the family. It runs in the family from the parents to the children, generation to generation. That is familial type. It is only 20%. Okay, it is only 20%. Okay, so that is the thing. And if it is familial, it is associated with MAN1, MAN2, MAN2A, MAN2B. I will explain you what is MAN2A, MAN2B. So you know MAN syndrome. Have you heard about MAN syndrome? Today I am going to teach you MAN syndrome also. I will teach you MAN syndrome. The sporadic is not associated with MAN syndrome. The familial is associated with MAN syndrome. What do you mean by MAN? MAN का मतलब क्या होता है? Multiple endocrine neoplasia. How many endocrine glands you have in your body? We have pituitary, we have thyroid, we have parathyroid, we have adrenal. These all are endocrine glands. These all are endocrine glands. You got my point? So if tumor occurs to multiple endocrine organs together, it's a syndrome. First understand the meaning of the MAN. MAN is not one malignancy. MAN is a cluster. MAN is a cluster of malignancies. Which malignancy? Say endocrine organs. So if there is multiple endocrine organ have the malignancy together, it is known as MAN. There are three types of MAN. I will tell you the details after the thyroid. I am coming on MAN only. MAN1, MAN2A, MAN2B. Currently I want to teach you in MAN2A and 2B. One of the malignancy is medullary carcinoma of thyroid. The remaining one I will teach you later on after thyroid only. But have a look. So MAN2A and MAN2B में medullary carcinoma is one of the malignancy because of multiple endocrine malignancy. Please learn that. Grossly, areas of hemorrhage and necrosis like follicular only. Areas of hemorrhage and necrosis are there, but microscopically something unique is there which is not present in any other thyroid malignancy. See, this is the microscopy of medullary carcinoma of thyroid. Medullary carcinoma of thyroid. What you can see? First see the arrangement. Always there is a rule. Set a rule. Whenever we study pathology, whenever we see the microscopy of any disease, we describe the arrangement of the cell, we describe the cells itself, and then any special property. So what is the arrangement here? Is it papillary? Say no ma'am, it's not papillary. I can't see. Is it follicle, small, goal, circular? No, it's not like that. It's small nest. These are the small nest. Can you see? What are these known as nesting pattern? So this is small nest are formed. Can you see? These all are nest. The tumor cells are arranged in small nest, also known as organoid pattern or nesting pattern. One and the same thing. Organoid. So what was the arrangement in papillary? Say ma'am, papillary itself. Over the fibrovascular core. What is the arrangement in follicular? See ma'am, small follicles were there. Tumor cells were arranged over the follicles. And what is the arrangement in the medullary? Say ma'am, tumor cells are forming small nest. This is first nest, this is second nest, this is third nest, known as organoid pattern. So I want to highlight you the pattern is different. How many of you are getting it? So the tumor cells are arranged in nesting pattern. Number one. The tumor cells are uniform. They all are looking same. They are uniform. The most important finding here, tumor cells are uniform. There is nothing important in the nucleus. So I have described the arrangement, I have described the tumor cell. No special property. There is something special present only in this, not in others. The background. The background pink color. Can you see in this slide? Let me erase everything. Can you appreciate something pink color in the background of the tumor cell? I want you to appreciate the background. Please appreciate the background. Something pink in the background. Let me highlight it. I will show you. Can you see this pink thing? The pink thing. What is that in the background? The pink color deposition. All the pink thing stuff. That is amyloid. So it is a unique tumor which is having amyloid as the stroma. The background is a stroma. So stroma is made up of amyloid. The amyloid stroma. No other tumor have amyloid stroma. Medullary carcinoma have amyloid stroma. And it secretes calcitonin. We already know because it is formed by parafollicular cells. It secretes calcitonin. And calcification is also there. See the blue color calcification. Can you appreciate? Let me highlight. The blue color calcification, this is a calcification, this is, so you will say, ma'am, we have seen the calcification in samoma, I mean papillary carcinoma also, but there the calcification was concentric, it was known as samoma. Here also calcification is there, but it's not concentric, so I will call only calcification. I will not call this calcification as samoma. No, this is not samoma, this is not samoma. Samoma is also a calcification, but it is concentric. Here it is not concentric, it is granular. Can you see here? It is like dot, 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 dot. It's not like this. So it is calcification, but not samoma. So say, ma'am, here we have calcification, but not samoma. How many of you got it? How many of you got it? You are getting it? So this is the slide of the medullary carcinoma. So the tumor cells are arranged in nest. They are uniform. Two unique properties. Number one, amyloid stroma, and number two, calcification, but not samoma. And it secrete calcitonin. ठीक है ना? What is amyloid? You know, have you read amyloid in pathology? Amyloid, what is the special stain to stain amyloid? You may have read this in general pathology. What is the special stain for amyloid? The name of the special stain is Congo red. Have you heard about Congo red? Hana? When you stain with Congo red, the amyloid look pink in color. It is pink in color. But when you use the polarized light, the same pink convert into apple green. See, Hana, the same pink converted into apple green. Wherever we have a pink color, it is converted to apple green. So on normal light microscope, it is pink color. But on polarized microscope, it is apple green color. So same Congo red. So Congo red have a special property for the amyloid. On light microscope, it give pink color. But on polarized microscope, it give apple green color. So we can do the confirmation. Just suppose I am having a female, Hana, she is having a neck swelling. She is having a neck swelling, her calcitonin blood levels are raised, and I am having high suspicion she is having medullary carcinoma of thyroid. So what is my next approach? I will do the biopsy. I will do the biopsy of this, and on the slide I can have the features. I'm not very sure, but I feel it's amyloid. It's medullary carcinoma, but I'm not sure. So I can apply the Congo red. Congo red on light microscope will be pink, and Congo red on polarized microscope will be apple green, and my diagnosis will be 100% confirmed. So you get questions on all these. I will show you the questions also. Students, people, please understand first. Okay. The last one here in the thyroid carcinoma is the anaplastic carcinoma. The last one. It is the most malignant, the worst prognosis. Most malignant, most aggressive, most rapidly growing. It occurs only in old age and 100% mortality. Worst prognosis. Now you tell me who is the best, who is the worst. The best is the papillary and the worst is this one. Okay, and this spread by invading adjacent organ. Hana, it goes by lymphatic also, hematogenous also, but mainly local invasion. The worst occurs in old age. Okay, grossly nothing important. Why? Tumor mein necrosis is abundant necrosis and hemorrhage. Histologically also, it's very poorly differentiated. Basically, three patterns are there. There are three patterns. Listen, can you see squamoid pattern? Spindle cell and giant cell. This is squamoid, this is spindle cell, this is giant cell. It will not come in your exam, just for your knowledge I am telling you. I am telling you anaplastic. So anaplastic have one of the three. Anaplastic have one of the three appearance. It is not fixed. Sometimes it is like squamoid. Can you see the cells are polygonal? The cells are polygonal. Sometimes it is spindle. The cells are spindle shape. And sometimes it is giant cell. The cells have multiple nucleus. So learn the three names just. Squamoid appearance in which the cells are polygonal. Spindle appearance in which the cells are spindle shaped, and giant cell in which the cells have multiple nucleus. So one of the three appearance, there is no fixed pattern. One of the three pattern will be present. So we are done, people. We are done with the 4 type of thyroid cancer. How many of you are with me? How many of you with me? So we are done with the 4 type of thyroid cancer: papillary, follicular, anaplastic, medullary and anaplastic. We have seen everything about them. Everyone, kindly respond. So you want to revise the microscopy? In the microscopy, let's revise the microscopy first here, and then I will show you the images of all 4. So you have to basically tell me the arrangement of the cell in each of them, number 1. Then you have to describe the tumor cell, each tumor cell, and then you have to tell me the specific unique finding which is not present anywhere else. I guess everyone got it. Okay, listen now. Arrangement here is papillary. Papillary is like finger-like projections over the fibrovascular stalk. Finger-like projections over the fibrovascular stalk. Follicular mein the arrangement is follicular. As the name indicates, they are small follicles. Medullary mein the arrangement is nest or organoid pattern. Small nest is there, and here no fixed pattern. No fixed pattern. Okay. Describe the tumor cells. Here the tumor cells mean the unique property is that the nucleus is clear, optically clear, known as any, orphan any nucleus, known as ground glass appearance, है ना? And it is having grooves and it is having inclusion bodies. These all special properties of papillary. Follicular may we have, what is the special property? Yeah, Samuma bodies also. I forgot to say. It is having Samuma body also. है ना? Samuma body is a special finding. Okay. It is a special finding. In the follicular, the tumor cell have a hyperchromatic nucleus. It is having hyperchromatic nucleus. Here, the tumor cells are uniform. Okay. And here tumor cells can be three patterns: squamoid, spindle cell and giant cell. Now tell me the unique property in each of them. Here I already told you the unique property is Samuma body. Never forget, Samuma body present only in follicular. Here the unique property is capsular invasion and vascular invasion. Okay, and Hurdle cell is a special variant here. Hurdle cell is a special type of follicular which is more aggressive. Medullary mein special thing is amyloid. The background amyloid which can be stained with Congo red. Which can be stained with Congo red, and calcifications are there. But calcifications are not Samuma. They are simple calcification. And in anaplastic, it's more deadly. It's very aggressive, no special property. Okay, Anna, how many of you got it? You see, these are the 4 diagrams of the papillary. We are done with papillary. The 4 diagrams of the papillary. Appreciate the papilla. First, appreciate the arrangement. I want you to highlight the arrangement. The arrangement is the papilla. The papilla on a fibrovascular stalk. Okay, then I want to highlight you each cell. In each cell, appreciate the nucleus is orphan Annie-like, optically clear, ground glass. Appreciate the grooving, appreciate the inclusion bodies. So appreciate all this. Okay, this is follicular. In the follicular, the arrangement is follicles and the nucleus is hyperchromatic, and a special variant is Hurdle cell. The special variant is Hurdle cell. But I want to appreciate 2 highlighted things here. The 2 invasion. Where is the capsule? Can you tell me where is the capsule here? Huh? Appreciate the capsule, the pink fibers. This is pink fiber. This is all pink fiber. So can you see the tumor cells are invading inside the capsule? It is invading inside the capsule. This is known as capsular invasion. Number 2, can you see the blood vessel? Where is the blood vessel? This is a blood vessel. So blood vessel have red colored blood. But what about these cells? These cells which are present here. These cells are the tumor cells which are entered in the blood vessel. So capsular invasion and vascular invasion. Never forget. Follicular. The third one is the medullary. Hana, first appreciate the arrangement. What does the arrangement say? The arrangement is nesting. Small nests are there. And the background have the stroma. The stroma is the amyloid, the pink color stroma. The background pink color stroma is the amyloid secreting calcitonin. Okay, and appreciate the calcification which is not Samuma. Simple calcification, not Samuma. Okay, and last one is anaplastic, this one. Having 3 patterns. It can be squamoid, it can be spindle, it can be giant cell. Okay, got it. Now we are ready to read this table. Okay, and we will solve the questions and you all are going to answer that. First, tell me the frequency. First, don't change the sequence. People, don't change the sequence. It is papillary, followed by follicular, followed by medullary, and followed by anaplastic. Hana, you can see the 4. Okay, these are the 4 together. You can see the 4. Okay, so here frequency wise, most common is papillary. Second most common is follicular, then medullary, and rarest is the anaplastic. Papillary occurs in all age. Anaplastic occurs only in old age. The remaining 2 are in middle age. Okay, all of them are more common in female, except medullary, which is male is equal to female. It's a question, please learn. Radiation is a risk factor for papillary. Maximum radiation is a risk factor for papillary. Okay, you can learn the genes here. The name of the gene which is mutated is RED and NTRK. Here the name of the gene is RAS and PX. Here also the RED and here P53. Learn the name of the genes which are mutated, which is leading to this cancer. Okay, all of them arise from follicular, except medullary, which arise from parafollicular. Okay, here main features are nuclear features. You know, grooving, inclusion body, orphan Ani, optically clear. Here main feature is vascular and capsular invasion. Here main feature is amyloid stroma. And here main feature is not fixed, it is undifferentiated. How many of you got it? Okay. And 10 years survival, this is the best and this is the worst. If 100 people have papillary carcinoma, 95 of them are going to survive after 10 years. Only 5 will die in the 10 years. But if 100 people have anaplastic carcinoma, only 10 will survive after 10 years. The 90 will die. See, the prognosis is just opposite. Here 90 are surviving, here 90 are dying. So this is the best, this is the worst. How many of you got it? Now are you ready for the questions? How many of you are ready with the questions? So will you answer it? Read the question, tell me the answer. Quick, fast. Read the question, tell me the answer. Quick and fast. So in thyroglossal cyst, okay, I forgot to tell you thyroglossal cyst is also a risk factor for the papillary. For the papillary, learn two risk factors. Number one, radiation. Number one is radiation exposure, and number two, thyroglossal cyst. Thyroglossal cyst is also a risk factor for the papillary. For follicular, the risk factor is iodine deficiency. Iodine deficiency, that is goiter. Learn the risk factor. Okay, coming on the next question. Orphan NEI nuclei is a characteristic of which type of thyroid cancer? Very easy question. Is it papillary? Is it carcinoma pituitary? Is it paraganglioma? Is it meningioma? I guess the question is very simple. Orphan Annie. I told you who is Orphan Annie. Orphan Annie is a cartoon character. The eyes are empty because she is orphan, no? So the eyes are empty. You can correlate. The eyes are empty. So the nucleus is empty in which of them? Yes, absolutely correct. Misty, Mariam, Kanish, Akash. Very good. The correct answer is A. Of course, it's papillary carcinoma of the thyroid. The Orphan Annie, also known as ground glass. Okay. And it is also known as optically clear. One and the same thing. These three are synonyms. Whether you say optically clear nucleus, ground glass nucleus, or Orphan Annie nucleus, the meaning is same. The meaning is same. So correct answer here is A. Got it? Can we go ahead? Okay. The next question. Okay, just a second. Most common thyroid cancer post radiation exposure. Post radiation. So radiation is a risk factor for what? Most common thyroid cancer post radiation exposure. Yes. Can you guess? Post radiation. Is it papillary, medullary, follicular, or none of the above? So radiation is a risk factor of, yes, again you all are right. Very correct. So of course the answer is papillary. Papillary, learn two risk factor, radiation and thyroglossal cyst. Thyroglossal cyst. So currently answer is papillary. But what if I change the question and instead of that, if I ask you most common thyroid cancer in iodine deficiency? In iodine deficiency, most common thyroid cancer. What would you like to change your answer in that case? You should change your answer in that case. What is the correct answer in that case? In iodine deficiency, which is the most common cancer which is going to occur? So in iodine deficiency, it will be follicular. Very correct. So it will be follicular. The follicular carcinoma will be there in iodine deficiency. It will be follicular carcinoma. Okay, please learn that. So all of the following are helpful for the diagnosis of medullary carcinoma of thyroid except. The question is regarding except. What is not present in medullary carcinoma? Please read it. Spindle cells present or not present with follicles? Amyloid stroma present or not present? Calcitonin deposition, calcitonin in the stroma, yes or no? And histologically, mitochondria is essential for the diagnosis. What is not present in medullary carcinoma of thyroid? Oh? So what is the correct answer? Yes? Can you give a guess? At least guess, na? What is the correct answer here? Yes? Yes. So the correct answer here is D. Mitochondria is not essential for the diagnosis. Amyloid definitely present, that is the hallmark. It secretes calcitonin because it is arising from parafollicular cell, and sometimes the spindle cell stroma is also there. Rarely. Mostly it is nesting pattern. 99%. But sometimes spindle stroma can occur. But mitochondria is not required. No, the correct answer is not A, it's D. Mitochondria is not required for the diagnosis. It is not a hallmark feature here. Okay, the next question. Which is the most common thyroid cancer? Frequency wise. Is it follicular, papillary, medullary, or anaplastic? Most common one. Yes? Of course, we all know. The most common is papillary, it's 75%. 75% is the frequency. If I change the question to the second most common, would you like to change your answer? Second most common corner. Which is the second most common among the following? Of course, the second most common, it is 20%. Nearly 10 to 20% is follicular. So second most common is follicular. Okay, which is the rarest? Again, I am changing the question. Which is the rarest? Now, would you like to change your answer? Which is the rarest? The rarest among them is the anaplastic. And it is only less than 5%. And this one is 5%. So please learn the sequence. You get question on most common, answer is papillary. Second most common, answer is follicular. And rarest, the answer is anaplastic. You have these questions. Okay. The next question. Medullary carcinoma of thyroid, which is associated with increase in what? Increase in calcitonin, increase in thyroglobulin, T3 or T4. What will increase in the blood whenever the person have medullary carcinoma of thyroid? Yes? What is the correct answer? Can you guess? What is the correct answer? Yes, the correct answer is A, of course. So calcitonin will increase in blood. Why? Why? Because medullary carcinoma arises from parafollicular cells, and parafollicular cells secrete calcitonin. It is not arising from follicular cells like other three carcinomas of the thyroid. Okay, the next question. MAN2 syndrome is associated with which thyroid carcinoma? Papillary thyroid, medullary thyroid, follicular thyroid or anaplastic thyroid? I told you what is MAN, multiple endocrine neoplasia. So which of the thyroid tumor which occur in man? Which of them? Which of them occur in man? Yes, of course, absolutely right. The correct answer is medullary. Absolutely right. The correct answer is medullary. Okay, so let's go ahead. The correct answer is medullary. Which type of thyroid carcinoma is classically associated with calcitonin induced amyloid deposition? Now two clues. Number one, calcitonin, and number two, amyloid. So of course we all know the answer. Calcitonin and amyloid, the two hallmark of medullary. So repeatedly they will ask you the same question. The language may be different, but the concept will remain same. You learn the concept, the language may differ. Okay, question to question. The next question, which of the following gene is mutated in medullary carcinoma? I told you the genes of all, है ना? So tell me the gene which is mutated in medullary carcinoma. The mutation of which gene leading to medullary carcinoma? Is it red proto-oncogene? Is it FAP gene? Is it retinoblastoma gene? Or is it BRCA1 gene? So what is the correct answer? Can you guess? Yes, absolutely right. So what is the correct answer? Yes? Can you people tell? Yes, absolutely right. It is red proto-oncogene. I know, red. Red occur in papillary also and medullary also. Okay. The next question, I guess everyone know. Which of the following is not true for medullary carcinoma? You tell me not true. They are arising from parafollicular C cell. C cell are parafollicular. It is a component of MAN1. MAN1. Is it multicentric in origin or amyloid deposition? What is not true? Tell me the false. What is false for medullary? The question is little bit tricky. Tell me what is the correct answer. Amyloid deposition, yes or no? Multicentric, yes or no? It is a component of MAN1. MAN1, no, it's not a component of MAN1. This is one. So it is a component of MAN2. Amyloid deposition is there, it's multicentric and it arises from the parafollicular C cell. We know that. But it is a component of MAN2, not MAN1. Okay. We are done with thyroid cancer. How many of you are satisfied? 100%. Huh? Now any question coming on that, we have solved all the previous year questions which are asked in NEET PG, FMG and INICET from this topic. So I have covered the major exams and all the PYQs and everything related to that. How many of you got it? Huh? So coming to the next, before coming to the next, let me tell you something. So whenever, you have a very big journey. I mean, you are starting as a medico student. So first the MBBS itself is 4.5 years, then internship is there, then you prepare. Meanwhile in the internship, sometime you have to take the drop, then your post-graduation for 3 years. After that you do super specialization for again 2-3 years, So it's a very big journey. Sometimes you feel very depressed, you feel very low. It happens to everyone, I guess, including me, to everyone, all the medicos. Sometimes we feel like that, but whenever you feel like that, always ask one question to yourself. Are your excuses are more important than your dreams? If you get the answer yes, it's okay. But if you get the answer no, just get up. Just get up and start working for your dreams. Okay, chalo. Coming on the next one. Okay, so let's come the next. Tumor and cancer are same, Sethi. They are the synonym. There is no difference in tumor and cancer. The tumor and cancer, these are synonyms. Okay. Sethi, have you watched my general lecture on neoplasia? Please watch it. The general lecture of neoplasia. The tumor and cancers are the same and they are of two types, benign and malignant. The tumor or cancer, whatever you say, they are of two types, the benign and malignant. Benign do not metastasize. The malignant one metastasize. So I have covered all these portions in the general neoplasia, but currently the answer is they all are same. Both of them are same. Okay. So let's go to the next. Next, we are done with thyroid tumors. We are going to cover 4 tumors today. We are done with thyroid, everything regarding thyroid. Now I am first covering the MAN syndrome. So endocrine tumors will be done and then we will move to the lung and the kidney. So let me come on the MAN syndrome. Can I go on the MAN syndrome? What is MAN syndrome? First tell me the full form. Multiple endocrine neoplasia, MAN. MAN syndrome. So how many endocrine glands we have? We have pituitary, thyroid, parathyroid, adrenal, multiple endocrine glands. So if multiple tumors occurs together of the endocrine gland, it is a syndrome. So basically it is a cluster of neoplasia, cluster of tumor. It is not one tumor, it's a cluster of tumor. So you have to learn. So there are 3 types of MAN. What is MAN? In which multiple adenomas and neoplasias occurs in the endocrine organs. It's a cluster of tumors. There are three type of man. First learn their name. Man 1, man 2A and 2B. There is no 3. Sometimes man 2B is known as 3 also, rarely. In some books it is written as 3. So man 1, 2A and 2B is better to say. What is the other name of man 1? Vermer, 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 Vermer syndrome. And what is the name of man 2A? It is Sippel, Sippel syndrome. There is no other name given to man 2B. So how many type of man in our syllabus? Say ma'am, we have man 1, man 2A and man 2B. Learn their other names, I insist. Vermer syndrome and Sippel syndrome. This is Sippel. Sometimes man 2B no other name, but sometimes it is known as man 3. So if man 3 comes, you must be identifying they are asking about the man 2B only. So let me tell you the differences between the three one by one. See the diagram, the beautiful diagram. Let me show you everything here only. See, this is man 1, this is 2A and 2B. Okay, now cluster of malignancies. You have to learn which one. Okay, so in man 1 it's triple P. P, P, P. The three P's are involved. Start with the brain. In the brain, pituitary is involved. Okay, number 1. Then in the neck. From the brain, move to the neck. Neck. In the neck, parathyroid, not thyroid. Over the thyroid, this is a thyroid gland. In the thyroid gland, we have two lobes. The right lobe, the left lobe, they are connected by isthmus. Now, on each thyroid lobe, we have embedded two parathyroid. So, total 4 parathyroid glands are present in our neck only over the thyroid. So, thyroid have two lobes, but there are 4 parathyroid glands. Okay, okay. So, can we go ahead? Huh? Okay, so the parathyroid gland is involved. And then come on the abdomen. Brain, neck, now come on the abdomen. In the abdomen, pancreas. Now tell me the tumor, which tumor? In the pituitary, it's adenoma. It's adenoma. In the parathyroids, it's simple hyperplasia. And in the pancreatic tumors are there. Which tumors I will tell you? Pancreatic tumors may, pancreas may insulinoma and gastrinoma. So learn the tumors also. Learn the organ. Say ma'am 3 organ. One is in neck, one is in brain, one is in neck, one is in abdomen. In the brain say pituitary. In the neck say parathyroid. And in the abdomen say pancreas. Now tell me the tumors. Say ma'am pituitary may adenoma. Okay. In the parathyroid simple hyperplasia. Okay. And in the pancreas say insulinoma ya gastrinoma. Insulinoma. So name the tumor also along with the organ. Say 3 organ and say their tumors. They occur together. So imagine a person coming to you with 3 malignancy. The person is having pituitary adenoma also. The person is having parathyroid hyperplasia also. And the person in the pancreas also having insulinoma or gastrinoma. So imagine you will label the person is having man 1. These 3 malignancies usually occur together. The 3 endocrine organs, that is man 1. Say yes if you got it. We are done with man 1. What is man 1? Say man 3P, triple P. Man 1. Man 1 is known as Vermer syndrome. Man 1. So there is mutation in mannin gene. The name of the gene is mannin. Mannin gene is responsible for the 3 organ. Which 3 organ? Pituitary, parathyroid and pancreas. In the pituitary, we have pituitary adenoma or prolactinoma to be specific. In the parathyroid, simple hyperplasia. And in the pancreas, it's insulinoma. Most common is insulinoma. Most common is gastrin, and second most common will be insulin. Gastrinoma followed by insulinoma. So that is man 1. You got it? Say yes if you all got it. So can I come on the next one? The next is man 2, man 2A, man 2A. Here also three things are there. Okay, let me tell you what are the 3 things. Here brain is not involved. Directly come on the neck. Directly come on the neck. In the neck again parathyroid is there. And thyroid is also there. So in the neck take 2 things. Don't take anything in the brain. Take 2 things from the neck. Thyroid, parathyroid. What happens on the thyroid? Say medullary carcinoma. I told you 4 types, na? Among them take the medullary only. And parathyroid again hyperplasia. And then come in the abdomen. But in abdomen don't take pancreas this time. No, don't take pancreas. Take adrenal gland. Adrenal gland. In the adrenal gland there is pheochromocytoma. Okay, so take the organs. You have to pick up the organs. You got my point? So what are the 3 things? You will say, ma'am, there is 2 in the neck and 1 in the abdomen. What are 2 in the neck? Thyroid and parathyroid. Thyroid mein medullary carcinoma and parathyroid mein hyperplasia. And we have one thing in the abdomen, that is pheochromocytoma, the medulla of the adrenal. Say yes. So learn the organ. Malignancy you will come to know. So in man 1, brain, neck and abdomen. In man 2, 2 in the neck. There is nothing in the brain and 1 is the abdomen. Okay. Coming on man 2B. Can I come? So man 2A is done. So learn the gene. Here it is red gene. In man 1, the name of the gene is mannin. Here the name of the gene is red gene. You know what are the three things. Now coming on man 2B. Here also the gene is red gene only. Let me show you the diagram. Here we have four things. Here we have four things. Number one, mucosal neuromas on the face. On the face, mucosa. Mucosal neuromas are there. है ना? The face is marphenoid body. Marphenoid body जैसा habitus जैसा face. So two things on the face. One is mucosal neuromas in the mucosa and marphenoid body habitus. And one is the thyroid that is medullary, and one is the pheo. You got my point? Say yes. I will draw three humans and show you the things. It's better to learn like this. Okay. So let me draw and you people can help me. Man 1, 2A, 2B. Can you please help me? We are drawing a rough diagrams. Man 1, man 2A. Let's draw man 2A here. It will be very easy for you to learn. Otherwise, you will get confused in the exam, which is a feature of man 1, 2A and 2B. But here you will never confuse. So can you start? Can you help me? Who will help me? Man 1, man 2A and man 2B. Wait. Man 1, you already know the other name. I guess we all know the other name, Werner syndrome. Here it is Sippel syndrome and here is no other name. Tell me the genes which are mutated. Here the name of the gene is Mannin. Here the name of the gene is Rett. And here also the name of the gene is Rett. Now you can start. So tell me three things in 1, 3 in 2A and 4 in 2B. Who will help? Anyone from the students? Yes, Akash, let me read your doubt. First tell me this. So can anyone tell me? Man 1, what are the three organs? First mark the organ. I will mark the organ as brain. I will mark the organ as neck. And I will mark one of the organ as abdomen. In the abdomen, I will mark pancreas. So in the brain, it's pituitary. Pituitary adenoma. Okay? Here in the neck, it's parathyroid. Parathyroid, hyperplasia. And here it's pancreas. In the pancreas, it's gastrinoma followed by insulinoma. Yes, very good, Sethi. Please everyone respond now. So learn the three organ with their cancer. Write down pituitary में क्या होता है? Adenoma होता है ना? Parathyroid में what will happen? Say hyperplasia will happen. और pancreas में क्या happen? Gastrinoma followed by insulinoma will happen. So this is the triad, triple P. है ना? Yes, Manish, Sethi, Misty, absolutely right. Now tell me the three organs in 2A. There is no brain involvement. No, the two organs in the neck. Two are in the neck. Say ma'am, one is thyroid and one is parathyroid. Okay. In the thyroid, we have medullary carcinoma of the thyroid. In the parathyroid, we have hyperplasia. And the third organ is in abdomen, but this time not pancreas, it's adrenal gland. Above the kidney. Say it's pheochromocytoma. Here we have pancreas. Pancreas mein gastrinoma and insulinoma. Here we have adrenal. Adrenal mein pheochromocytoma. So learn the organ, learn the tumor. I want you to learn the organ. Tumor automatically come in your mind. So just learn the organ. So see the three organs here and see the three organs here. Okay, can I come on the third one? Can you please help me? Absolutely right, Sethi. Manish, absolutely right. Coming on man 2B. In man 2B, two things on the face. Number one, mucosa. Mucosal neuromas. I will write mucosa. Mucosal neuromas. Number two, face. Mein marphenoid habitus. Marphenoid habitus in the face. Okay, number two. Number three, we have medullary carcinoma of the thyroid. Not parathyroid here. We have only medullary carcinoma, only thyroid. We don't have parathyroid in the neck. MCT. And here again we have pheochromocytoma. Pheochromocytoma. You got my point? Say yes. Shall I repeat or done? Everyone done it. I am repeating it once again. Please understand. Man 1 to A to B. This is the best way you can learn. Okay. So I am flipping it. Listen everyone. So man 1. Man 2A, there is another way to learn. If you are getting confused there, learn like this. Man 2B. Okay, learn the organ, the three organ. Say, ma'am, it's brain. Okay, it's neck. Okay, and it's abdomen. Okay, now tell me the organ, I mean the tumor. In the brain, say, ma'am, it's pituitary. Pituitary adenoma. In the neck, what is there? Say, ma'am, parathyroid, not thyroid. Parathyroid hyperplasia. And in the abdomen, it's pancreas. It's pancreas. Pancreas ka kya? Gastrinoma followed by insulinoma. So learn the organ with the tumor. Now learn the three organs here. There is no brain. Directly come on the neck. But in the neck we will take two organs here. And one is abdomen again. So two organs in the neck and one in the abdomen. So what two organs in the neck we are taking? One is thyroid and one is parathyroid. Okay. In the thyroid it's medullary carcinoma. Parathyroid is same. That is hyperplasia. hypertrophy, hyperplasia, है ना? And in the abdomen organ is changing. Here it was pancreas. Here it is adrenal gland. The medulla of the adrenal having pheochromocytoma. So tell the organ, tell the tumor. Tell the organ, tell the tumor. Okay. So this is the triad here. Coming on man 2B. Here we have face, not the brain, but we have the face. On the face we have two things. You have to enumerate the two things on the face. Okay. One in the neck, not two. One in the neck and one in the abdomen. Okay. So what are the two things on the faces? Number one, mucosa, mucosal neuromas. Okay. Mucosal neuromas. And number two, marphenoid face. It is marphenoid face. In the neck we have only thyroid, not parathyroid. So thyroid is same like medullary, and here also adrenal is same. Okay. Adrenal pheo. So if you learn with the mnemonic now you will get confused, but with the organ I never confuse. I know the organ, the three organ in the 1, the 3 organ in the 2A, the 3 organ in the 2B. If you know the organ you can come out which malignancy in which organ. It's very easy to learn. How many of you got it? Now you get many questions. The section is very small, but you get many questions on that. Believe me. You want to try? Who want to try? Read it and tell me the answer. Quick. Medullary carcinoma of thyroid is associated with which of the following? Man 1, Man 2, Liefroni or Hashimoto? Man 1, Man 2, Liefroni, Hashimoto. Man 2 means Man 2 both, A and B. They have not mentioned separately. Yes, Misty, absolutely right. What about others? You are still thinking? Yes, yes, Manish, yes, Walker. Everyone is right. So it is Man 2. In Man 1, we have parathyroid, not thyroid. But in Man 2A, 2B, in both of them, the thyroid is there. So correct answer is Man 2. Werner syndrome is which one? Man 1, 2A or 2B? Werner. What is the other name of the Werner? Werner is given to which man syndrome? So we all know Werner is absolutely right. It's Man 1. And if I change the question to Sippel, would you like to change your answer? You should change your answer now. What is the correct answer in that case? If Werner is replaced by Sippel, what is the correct answer here, people? If Werner is replaced by Sippel, yes? What is the correct answer? Yes, absolutely right. In that case, answer will become 2A. 2B don't have any special name. So Werner and Sippel usually come in the question. Now please read, which is not a component of Werner. Which is not a component of Werner. Werner is 1. So what is not there in 1? In the 1, we have 3P, triple P. In the 1, we have triple P. Okay, G? In the 1, we have triple P. No? So what is not there? So of course, we have one organ in the brain, pituitary. We have one organ in the neck, parathyroid. And we have one organ in the abdomen, that is pancreas. We don't have adrenal here. Adrenal is involved in remaining 2, 2A and 2B, but not in 1. So incorrect among them is adrenal. So if you know very clearly the organs and the tumors, then only you can answer. Okay. The next question, which is not included in Sippel? First tell me what is Sippel. What is Sippel? You tell me. You tell me. Say, ma'am, Sippel is 2A. So tell me the 3 components of 2A. Is it brain? No. 2 things in the neck. 2 things we take in the neck and 1 in the abdomen. And that is the triplet here, the triad here. So what 2 things in the neck? Say, ma'am, we take thyroid, we take parathyroid. And in the abdomen, we take adrenal, not pancreas. In the thyroid, there is medullary carcinoma. In the parathyroid, there is hyperplasia. And in adrenal, there is pheochromocytoma. Now check. Pheo is there, medullary is there. And hyperthyroid or parathyroid means what do you like to say? Would you like to say hyperthyroid or hyperparathyroid? Parathyroid is there. Okay. And hyperthyroidism is not there. No. Hyperthyroidism is not a feature. You will say, ma'am, thyroid is involved. I agree thyroid is involved. But it's medullary carcinoma. See, medullary carcinoma means calcitonin rise. T3, T4 do not rise. Whenever there is hyperthyroid, parathyroid, hyperplasia, the parathyroid will definitely rise. But whenever there is a medullary carcinoma, the calcitonin will rise. Just now I taught you. Just now. So hyperthyroidism is not a feature. You are getting confused, or is it good to go? So hyperthyroidism is not a feature because here we have medullary carcinoma and that will increase the calcitonin. The question was tricky, really very tricky. Many of you can get confused. Okay, can we proceed? The next question. Man 1 include all of the following except Man 1. What is not present in Man 1? In Man 1, you know the 3 organ, brain, neck, abdomen. Tell me what is not present in Man 1? In the brain, we take pituitary. In the neck, what do you take? You take thyroid or parathyroid? That is the question. In neck, you have to take 1. P, parathyroid. Don't take thyroid. And in the abdomen, take pancreas. So thyroid is not a component of Man 1. So you all are right. The correct answer is D. So there is a very big confusion between man 1, 2A, 2B, but I tried my best to explain you in the form of the diagrams. Okay, yes, it's triple P. So correct answer is D. The next question, all of the following are involved in man type 2A except. What is not involved in man type 2A? They are asking for simple. Tell the three organs, two in the neck, one in the abdomen. What two in the neck we have? We have parathyroid and thyroid in the neck. What we have in the abdomen? In the abdomen we have adrenal, but brain is not involved here. Brain is not involved. Pituitary involved only in one, not in 2A, 2B. So correct answer is D. So in the same way you get many questions. You got my point. Commonest thyroid tumor in man. So we already know the answer. Is it follicular, papillary, anaplastic or medullary? In man 2A as well as 2B, which thyroid malignancy is there? So of course it's medullary. Absolutely right. It's medullary. Okay. Next question. Most common thyroid cancer associated with man 1. Okay. Man 1 में तो thyroid है ही नहीं. Leave it. So we are done. Okay. So we are done with thyroid. We are done with man. Can I start the lung tumors? Are you people with me? Can we start lung tumors? How many of you are with me? Give me a thumbs up. Can I start lung tumors? And after that we have to go to kidney tumors also. So one by one in this way we are going to cover entire oncology. So let's start the lung tumors. We are done with thyroid tumors, the 4 type of thyroid tumors, papillary, follicular, medullary, anaplastic. We are done with 3 type of man 1, man 2A, man 2B. We have seen the various combinations and syndromes, the cluster. And now coming on the lung tumors, I will teach you 5 type of lung tumors. Okay, so let's start lung tumors. Lung tumors. Lung tumor is the most common cause of cancer related death in the world. So there are many cancer from head to toe we can have. I mean humans can have cancer in any part of the body from head to toe. So cancer can lead to death if it is malignant metastatic. So among the cancer related death, most common cause is the lung cancer. I'm not saying lung cancer is the most common cancer in the world. No, lung cancer is not. Lung cancer is the most common cause of cancer related death in the world. Okay, most commonly it occurs in males. Males may more common because smoking is more common in males, but nowadays females are also smoking. So you know the prevalence is nearly becoming equal, but although it is more common, relatively little bit more common in the males, and it occurs in 40 to 70 years, relatively in old age, relatively. So whenever you start any malignancy, tell me the gender in which it is more prevalent and tell me the age. Gender and age is always important. You got my point? Gender and age is always important. Okay, now let's talk about the children. Let's talk about the children. In children, what is the most common lung tumor? First we will see in children and then we will see in adults. Lung in children. Tell me the most common lung tumor. In children. In children the most common lung tumor is not primary. It is metastatic. You know the difference? There are 2 type of tumors. There are 2 type of tumors in any organ. Primary and metastatic. Metastatic also known as secondary. Primary and secondary. Secondary is metastatic. I mean there is any organ. For example, this is an organ. Any organ. If tumor de novo occurs in this organ only, it is primary. The tumor of this organ. But if tumor occurs in any other organ of the body, and it is metastasizing in this organ. So the tumor, if it is coming due to metastasis, not of this, some other tumor is coming, some other organ tumor, it is known as secondary. So in lung, the secondaries are common. Primaries are not that way common. The most common tumor in the lung is metastasis. Hana, so which metastasis means it is coming from some other tumor. So name the primary tumor which send its metastasis to lung in children. So in children, osteosarcoma followed by Wilms tumor. Osteosarcoma and Wilms tumor both are more common in children. So osteosarcoma of the bone and Wilms tumor, they send their mets to the lung in children. Okay. Now tell me the most common tumor, benign tumor in children. The answer is inflammatory myofibroblastic tumor. It's a question. Most common benign tumor in infants. Infants is up to 1 year of age. This is overall children up to 18 years. This is up to 1 year. In the 1 year again, benign is pleuropulmonary blastoma. This was inflammatory myofibroblastic tumor. This is pleuropulmonary blastoma. Okay. And most common malignant tumor in the children, it is bronchial carcinoid. You have to learn. I know it's difficult. So tell me the most common tumor in children. We are talking about children. Overall, not benign, not malignant. Which is most common? Most common. Second, tell me the most common benign. Then tell me most common malignant in children. Overall most common benign, most common malignant. Most common benign you tell me separate in infants and you tell me separate in children. So this is the question. 4 questions I put. Overall most common if you say, I will say metastasis. Overall most common benign in infants. What is there in infants? In infants it's separate and it's in infants it's pleuropulmonary blastoma. and in children it's inflammatory myofibroblastic fibrosis, है ना? And most common malignant is carcinoid. It is carcinoid. You got my point? So please learn it. How many of you got it? These all are one-liner questions. This is in children. Now coming on the adults. In adults again the same question. Most common overall, most common benign, most common malignant. The three questions. So overall most common is METs, or like children only. But here the primary is the breast cancer. Okay. The benign is pulmonary hamartoma. And malignant, in India it is squamous cell carcinoma, in the world it is adenocarcinoma. You are getting it or getting confused? Shall I write it again? Huh? I will write it again. Okay, I will write it again once more. Everyone here on the screen. Listen, I want to ask you three things. Three things in children and three things in adults. You will answer. See how confusing question come in your exam. Tell me overall most common lung tumor. Most common lung tumor in children, in adult. है ना? Most common lung tumor overall. I am asking most common benign tumor. And I am asking most common malignant tumor in children, in adult, in children, in adult, in children, in adult. Who will tell me? First tell me overall most common. Overall most common. Here also METs, here also METs, not primary in both of them. If there is a METs, someone may be sending its metastasis to the lung. So name the primary. Who is sending here? Here it is osteosarcoma followed by Wilms tumor. Here it is breast cancer. So breast cancer send the malignancy to the lung, metastasis, and here osteosarcoma and Wilms send the metastasis to the lung. But it is METs in both of them. See the most common benign in both of them. Here the most common benign is inflammatory myofibroblastic tumor. And here the most common benign is hamartoma, pulmonary hamartoma. Most common malignant, here the most common malignant is carcinoid. Okay, and here most common malignant is different in the world, is different in India. Okay, if you talk about the world, I will say adenocarcinoma. If you talk about the India, I will say squamous cell carcinoma. How many of you got it? And here one more thing, most common benign is this. But in infants, if you ask separately most common benign in infant, my answer is pulmonary blastoma. How many of you got it? I tried my best to explain you. Come on. No one will explain you with such a clarity. Please learn most common tumors of the lung in children, in adult. Overall most common benign, most common malignant. Give me a thumbs up. I tried hard. Please write down. Please understand if you want. Can we proceed? So this is the thing you have to learn. Now let me ask you 6 questions. There are 2 main tumors in the lung, adeno and squamous. Let me ask you 6 questions. Tell me most common lung cancer. Tell me most common lung cancer in the world. And tell me the most common, just now I told you, most common lung cancer in India. Okay, the 2 questions. Take your world and India. Tell me most common lung cancer in females. And tell me most common lung cancer in males. Again 2 questions. Tell me most common lung cancer in non-smokers. And tell me most common lung cancer in smokers. So 6 questions I want to ask. Can you answer the 6? It's very confusing. That's why I'm telling you all the most common together, and then we will start the tumors one by one. But let me tell you all the most common together. Okay. So most common in the world, you say, my answer is adeno. But in India, it's squamous. It's squamous cell carcinoma. In the females, again it's adeno. But in males, again it's squamous. In the non-smoker, you can learn females are usually non-smoker. Usually, I'm not saying always. Females are usually non-smoker. So it's adeno only. Okay. And males are usually smoker. Smokers are usually male, you can say. Okay. So it's squamous. You can correlate like that. Okay. So this is the same thing. You can learn the 6 questions, the 6 answers. They can come in your exam. The 6 questions, 6 answers. Please learn the world and India. And then you can learn the male and smoker. In both of them, it is squamous cell carcinoma, and the female and non-smoker. In both of them, it's adeno. How many of you got it? So please learn that. The same story is written in front of you. Adeno is overall most common in the world. Overall means world. But squamous is most common in India. ठीक है? Adeno is most common in non-smoker and in females. Squamous is most common in smoker and male. Say yes. Got it. Can we go ahead? Now, coming on the histological type. How many type of lung cancers are there? Total, how many type of lung cancers we have? We have 5 type of lung cancers. Okay, how many type? Total 5 type of lung cancers. Squamous cell carcinoma, also known as epidermoid carcinoma. small cell carcinoma, okay, adenocarcinoma, large cell carcinoma and combined. These are the 5 types: lung squamous, adeno, small, large and combined. Combined are very rare. So it's squamous, it's adeno, okay, the pair, then small cell, then large cell, again the pair and the combined. So total 5 are there. Listen my point. Among them, the worst is small cell. So I will take small cell separately and remaining all I will call non-small cell. This is clinical classification. Clinically we are more concerned whether it is small cell or non-small cell. In the non-small cell, whether it is squamous or adeno or large cell, we don't bother because treatment of the remaining 3 is same. But the treatment for small cell is different. So I will tell you 2 classification. What are the 2 classification? Please see. First tell me histological classification and then tell me clinical classification. In histological classification, we have 5 categories. What are the 5 categories? Just now I told you. Say, ma'am, it's adeno, it's squamous, okay, it's small cell, it's large cell, and last is combined, okay, combined. So these are the 5 categories we have. But clinically, we want small separately and remaining all separately. So clinically, we have 2 or 3 categories. The combined be separately low. So it's small cell, the remaining all will be non-small cell, okay, and last is combined. Okay, combined is combined. So non-small cell include adeno, squamous and large. Here you can write in the back bracket, adeno, squamous and large is included in non-small cell. How many of you got it? Because treatment wise, small cell is different and remaining all is same. So that's why we are not separating the others. Say yes, people. So learn the 2 classification of the lung cancer. Here I taught you the 2 classification of the lung cancer. What are the 2 classification? Histological classification in which there are 5 type of lung cancer and clinical classification in which only 3 type of lung cancer. Got it? Can we go ahead? So histological and clinical. In the clinical also you can see it's small cell, non-small cell and combined. Small cell is 25%, the non-small cell is 75%, which includes squamous, adeno and large cell. Say people, say yes. Say T, nomads, Akash. Huh? You all got it? All those who are attending me live. What is the etiology? The most common risk factor is smoking. The most common risk factor is smoking. Please listen. Please listen. Among all the lung cancer patient, all the patients who have lung cancer, who are positive for lung cancer, 90% are smokers. Please see the percentage. 90% of them are smokers. 90%. If you ask them, do you have a history of smoking? They all say yes. 90% of them say yes. Only 10% they say they will crib like, no, even we don't smoke, even we have the lung cancer, we are very unlucky. We don't smoke, still we have the lung cancer. Only 10%, but 90% are smoker. You got my point? Now, among all the persons who smoke, there are total all the persons who smoke. Do you smoke? If anyone you know you smoke or anyone you know you smoke, quit it immediately. Quit it immediately, okay? It's not good thing at all, okay? All the persons who smoke, among them 10% have lung cancer. So see the 2 statement, जितने लोगों को lung cancer होता है उसमें से 90% smoker होते हैं और जितने लोग smoke करते हैं उसमें से 10 को lung cancer होता है. You got my point? So anyone can be among this 10 and that will constitute the 90% of the lung cancer. How many of you got it? How many of you got it? So smoking is the biggest risk factor. And I told you, among all the smokers, now among all the lung cancer patients, 90% of them are smokers. What about the remaining 10%? The remaining 10% don't smoke. Still they have the lung cancer. What's the trigger in them? What is the trigger in them? What's the trigger in them? It can be radiation exposure. It can be atmospheric pollution. It can be occupational hazard. It can be dietary factors. And it can be chronic scarring like TB or some chronic scarring disease. So other minor risk factors are there, but major is smoking. Major is always smoking. Now grossly, if we see the lung cancer, have a look here. If we see the lung cancer can occur like this. Can you see here? The lung cancer can occur like this. It is known as central. It is around the hilum. You know the hilum. Hilum is the point at which the bronchi enters the lung. That point is known as hilum. So it is known as hilar type, also known as central type. Central type. It presents very early because it will compress the hilum now. So patient have dyspnea, breathlessness. So it presents very early. They will come for the checkup and get diagnosed. But sometime it is at the periphery. This is known as peripheral type. Sometime. So they are very late presenter. So they will expand and then when they will involve the bronchi, then they will present. So it's too late. So these are early presenters. These are late presenters. These are central, perihilar, also known as perihilar, and these are peripheral. Got it? There are two locations, either around the hilum or away from the hilum. If it is around the hilum, it is central. If it is away from the hilum, it's peripheral. Say yes. So that is the grossly two patterns are there. Can I go ahead? Now, I will not teach you combined. I will teach you remaining four. What are the four types? First, I will start with squamous. I will teach you squamous in detail. Then I will teach you, after the squamous, the second one, adeno. I will teach you adeno in detail. After that, I will come on small cell and finally large cell. So combined, I am not teaching you, it's very rare, and in which combinations are there. So we will see these four one by one. We have seen four cancers in the thyroid: papillary, follicular, medullary, anaplastic, and now I am teaching you four cancers in the lung: squamous, adeno, small and large. One by one we will start. Hana? So we will see this table in the end. I will show you this table again in the end. Hana? Let's start with squamous. Then we will move on adeno. Then we will move on small cell. Then we will move on large cell. Keep interacting. Say something. Can I start? So let's start with squamous. This is the sequence I will take. And then we will do a comparative analysis of all of them. That's it. Okay. Let's start with squamous, I'm sorry. We know squamous is the most common in India, not in world. In the world, adeno is most common. We know squamous is most common in smoking, not in non-smokers. Non-smokers, adeno is more important. Okay, got it? And it is always central, hilar. Central or hilar. Please learn. I told you two presentation, central or peripheral. This one is central. This one is central. Now, this is the important points. Now, I want to tell you the microscopy of all of them. This is the microscopy of squamous. You have to learn the four microscopies. This is the microscopy of squamous. I always insist from the very first line in today's lecture, I am insisting. Whenever there is a slide in front of you, there is a peculiar way. First, describe the arrangement of the cell. Then tell me the cell morphology. And then tell me any special feature. So, what is the arrangement of the cell? You can see these all are tumor cells. So, tumor cells are arranged in sheet. They are forming a sheet. It's not papilla, it's not follicle, it's not small nest. No, it's in sheet. So say, ma'am, the tumor cells are arranged in sheets. It's not written here. You can write it's arranged in sheet. Number one. Now describe the tumor cells. The tumor cells, what is the shape? See, ma'am, they are polygonal in shape. You see, most of them are like polygonal. Big cells are there. Polygonal. So shape is polygonal. They are polygonal with a central nucleus. Special finding are two. Can you see something pink color? Let me highlight. Can you see this pink color? Pink color whorl. Can you see one more pink color pearl? What is this pink color here? This is keratin. This pink color is known as keratin, and this pearl, it is known as keratinization. Keratinization pearl or whorl. Keratin pearl or whorl is something unique here. So keratin form the pearl or whorl. It is present extracellular also forming this pearl whorl, and see the cytoplasm of all these cells. Any cell. See any cell. कोई भी cell देख लो. See the cytoplasm. The cytoplasm also have this pink color. So keratin is present intracellular as well as extracellular. So keratinization is there in the cytoplasm also and extracellular also. Keratinization is the hallmark. So main feature here is keratin, pearl, whorl, whatever you say. So you will say, ma'am, what we are learning? We are learning squamous cell carcinoma. What we have learned? We have learned this is the most common type in India, number one. This is the most common type in smokers, number two. This is the most common type in males, number three. We have seen. And we have seen it is central in location, hilar in location, not peripheral. So it is an early presenter. Then we have seen its microscopy. In the microscopy, we have seen the cells are arranged in sheet. Okay, the cells are polygonal in shape. Okay, polygonal in shape. And we have seen the keratin is present. Keratin extracellular hai, it form the pearls or whorls. And intracellular hai, so it is giving pink color to the cytoplasm. Pinkishness in the cytoplasm, that is a summary. This is what you have to learn. Is there is a marker? The marker is cytokeratin known as CK. Cytokeratin. Just suppose, I am looking at the slide. You are a surgeon and you are resecting a lung tumor in your patient and sending it to me. I am a histopathologist. You are sending it to me, ma'am. I am sending you a specimen of lung cancer. Can you have a look, or you are sending a biopsy? So in the biopsy, I am getting confused. Is it squamous or adeno? Treatment is different, no? Or is it small cell? I cannot report anything. It's a lung cancer. I know it's a lung cancer, but which one? So if I have the confusion, I can use the marker. Cytokeratin will highlight only squamous, not others. So cytokeratin is a marker which is unique for squamous cell. So in case of confusion, we use cytokeratin and confirm our diagnosis. So please learn the word cytokeratin. Can I come on the second one? We are done with the first one. Can I come on the second one? Say yes. The second is the adeno. Let's start with adenocarcinoma. We are done with squamous cell carcinoma. Now coming on adeno. Adeno is most common in world, not in India. World matlab overall. So adeno is most common overall. It is more common in females, not males. It is more common in non-smoker, not in smoker. And this one is peripheral in location. See, everything is opposite. Anna, squamous was more common in India, this is most common in world. Squamous was more common in male, this is more common in female. Squamous was more common in smoker, this is more common in non-smoker. Squamous was central or hilar, this one is peripheral. These all are your PYQs. People, please understand. Okay, Hannah, this is more slowly growing, more slowly because it is peripheral, no? It will take time and it is metastasizing metastasizing earlier because presentation is very late. Till the person come to know that I am having adenocarcinoma, it's already metastasized because it is peripheral. Patient don't have symptom. By agar symptom hi nahi hai, to why the patient will take the treatment? So peripheral are late presenter, you can see. Okay, now what is the diagram? There are 4 types. Adeno is of 4 different types. I will show you all 4 diagrams. Number 1, it can be SNR. What do you mean by SNR? See, don't learn the diagram, just have a look. See, what do you mean by SNR? Let me explain you the meaning of the SNR. Here the tumor cells are arranged in glandular pattern. SNR means the tumor cells are arranged in glands. Can you see? These all are gland. So tumor cells are arranged in glandular pattern. This is SNR. SNR means tumor cells arranged in glandular pattern. Learn that. Most common pattern is SNR. Second is papillary. You may be knowing what is papillary. The tumor cells are arranged in papilla. The tumor cells are arranged in papillary pattern. They are like papilla. Can you see the papilla? They are arranged like papillary pattern. Appreciate the finger-like projection. Arrangement is different. Here the arrangement was glandular. Here the arrangement is papillary. The third is most common. The third is bronchoalveolar or lapidic. Very important. Very, very important. It's bronchoalveolar or lapidic pattern. What do you mean by bronchoalveolar? Lung is made up of acini. Do you know? Like the entire kidney is made up of glomerulus. Like the entire lung have acini. What is acini? It is a structural and functional unit of the lung. So these all are the acini. Can you see? These are the acini in the lung. Ye acini. So tumor cells are running over the acini. Mind my words. Tumor cells are running over the walls of the acini. This is known as lapidic. Lapidic means these are acini only. Please appreciate the tumor cells are running over the acini. They are running over the acini. I repeat my words. So here the tumor cells are growing on the pre-existing alveoli, alveolar acini, alveolar acini. And here a unique cells are present. The tumor cells are known as Clara cell. The unique cells are Clara cells. The unique cells are Clara cells present here. No other tumor have. And the last pattern is the solid. The last one is the solid. The solid pattern. Can you see? Oh, I'm sorry. This one is papillary. Okay. This one is solid. Can you see? This one is solid. Compact, solid. Okay. This one is papillary. This one is papillary in which the tumor cells are arranged in papillary pattern. So what are the 4 patterns adeno ke? Can you tell me what are the 4 patterns? The first is SNR. The second is papillary. The third is lapidic. Lapidic is also known as bronchoalveolar. Bronchoalveolar. You have to say all these terms. Bronchoalveolar. And the last one, the 4th one, is known as compact. You have to tell me the arrangement. Here the tumor cells are arranged in glandular pattern. Here tumor cells are arranged in finger-like projections. Here tumor cells are arranged over alveoli, pre-existing alveoli only. They are not forming anything extra, pre-existing alveoli. And here tumor cells are arranged in sheets, compact sheets. Say yes, people respond. Among these, the most important is this one. It is unique, and here Clara cells are present. Clara cells are present. It is the most common tumor, this one, bronchoalveolar lapidic, that metastasizes from one lung to another. Please mind my words. Humans have 2 lungs, the right and the left. So if someone is having a tumor in the right, can it metastasize to the left? Or if someone have tumor in the left, can it metastasize to the right? Say yes or no. You say, ma'am, of course it can. So most common lung cancer which go to the opposite lung, whatever it is, right to left or left to right, vice versa. So it is this one. It is this one. It's a very important question. Please learn. Got it? So these are the 4 types of the adeno. We are done with 2 till now. We are done with squamous. We are done with adeno. 2 more to do. Small cell and large cell. So total 4 types of lung cancer are there. We are done with 2. Let's revise 2. So this is most common in India. This is most common in the world. This is most common in smoker and males. This is most common in non-smoker and females. Not only this. This one occurs at the this one occurs in the central location or hilar location. This one is peripheral. Okay? Now tell me the microscopy. In the microscopy here, tumor cells are arranged in sheets. They are polygonal and main thing is keratin. Extracellular, intracellular. Extracellular, it is forming pearls or walls. Say yes. है ना? In the adeno, say ma'am, 4 patterns are there. It can be acinar, है ना? Like the tumor cells are arranged in glands. It can be papillary, in which the tumor cells are arranged in papilla. It can be lapidic, that is bronchoalveolar, in which tumor cells are there on the pre-existing alveoli. And last is compact, in which tumor cells are in sheet. है ना? Lapidic is most important, in which clara cells are there. पहली खास बात, the first important point is clara, and second important point, it metastasized to opposite lung. It metastasized to opposite lung. How many of you got it? Now coming on the third one. Let me come on the third one, small cell. Ultra important. First learn the other name of the small cell. Small cell carcinoma, also known as oat cell carcinoma. Small cell carcinoma, also known as oat cell carcinoma. Learn the other name. It is also known as oat cell carcinoma. It is having a strong relationship with the smoking. Okay. It can occur in the central also, peripheral also. Squamous was central, adeno was peripheral. This can occur both. This can occur both. Please learn. This can occur both. Yes, absolutely right. Both. Now see, the histology is very unique. The histology is very, very unique. Okay. The first thing, tell me the pattern. Arrangement, I mean. What is the arrangement? You will see, ma'am, again these are small, small nest. This is a nest. This is a nest. So pattern is nesting. Pattern is nesting. Like the medullary carcinoma of thyroid. The pattern is nesting. Now describe tumor cell. Very unique tumor cell. I can see these are the lymphocyte. Have you seen the lymphocyte in the blood? Can you see? The tumor cells are very small. The first thing, they are small. I can see the blue colored thing. Now, this blue color is the nucleus. Where is the cytoplasm? I can see this is a nucleus, this is a nucleus, this is a nucleus. I mean, where is the cytoplasm? You see, the cytoplasm is very scanty, hardly seen, very scanty. These are small tumor cells, scanty cytoplasm. I can't see the cell lining, cell border. I can see only nucleus, 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 nucleus. These all are blue nucleus. So, ill-defined border. Ill-defined border. Please see, pathology, histopathology is the easiest thing in the world ever. Whatever you see, just write down. I can see cells are small, I have written small. I can't see the cytoplasm, I can see only blue color nucleus, I have written scanty cytoplasm. I can't see the cell membrane, cell borders, so ill-defined borders. What is the color of the nucleus? Say blue nucleus. So, and what is the shape? Round. So, these are known as small round blue tumor cell. Small round blue tumor cell. Hai And what is this pink color? Abundant of necrosis. It is showing abundant of necrosis. So, say scanty cytoplasm, ill-defined, poorly defined cell border. The cells are small, looking like lymphocyte. They are blue. They have high mitotic count. They have high necrosis. Listen, listen, listen. I can't zoom it out more. I'm sorry, but I wish if I could. I wish if I could. So the cell is like this. This is a cell. This is a cell. Okay. Most of which is occupied by the nucleus. Hardly any cytoplasm. Hardly. Scanty cytoplasm. Now, if I could zoom out, I could show you the nucleus is having like this. Inside which the nucleus is granular dot 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 appearance is there. This appearance is known as salt and pepper. Salt and pepper. Have you ever tried mixing salt and pepper? What is salt? Salt is white in color. And what is pepper? The black pepper, black in color. So it's white, black, the dot dot dot. Black, white, black, white, black, white. This appearance is known as salt and pepper. So I can't show you it here, but you can imagine all the blue nucleus are dot 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 from inside. Peculiar salt and pepper pattern. Please learn the granular nuclear chromatin. The granularity leads to salt and pepper. You get many questions on salt and pepper. Please learn salt and pepper, people. Learn it. Learn it. Salt and pepper appearance. Okay, so salt and pepper is very unique thing here. One more unique thing I would like to tell you. These tumor cells secrete nuclear chromatin out. The nuclear chromatin is secreted out, the tumor cells, and that nuclear chromatin will go and stain the walls of the blood vessel with the blue color. Let me draw it. Okay, let me draw a blood vessel. This is a blood vessel lined by the endothelial cell. The blood vessel look red in color, and these all are the tumor cells. In small cell carcinoma, the tumor cells. Now, when the tumor cell, it is having the salt and pepper appearance. When the tumor cell will rupture, the nuclear chromatin will leak out. The nuclear chromatin will do the blue coloring lining of the blue lining of the blood vessel. This blue lining of the blood vessel done by the nuclear chromatin of the tumor cell is known as azopardy effect. Again, a very important question. So you get two questions here, है ना? Small cell carcinoma. Small cell carcinoma. Okay, you get two important highlights here. Number one, it shows salt and pepper appearance, है ना, of the nucleus, and number two, it shows azopardy effect. What is azopardy effect? Mishti, others, what is azopardy? Huh? Azopardy, the nuclear cell is ruptured, necrosed. The chromatin leak out, and this chromatin is giving the blue color, the basophilic color to the vascular blood vessel lining. This is azopardy effect. How many of you got it? How many of you got it? So what we are learning? We are learning the third type of lung cancer, small cell carcinoma of the lung. I am teaching you the third type. The third type is the small cell carcinoma. Please understand that. Okay. First tell me its other name. The other name is very simple. You say, ma'am, oat cell carcinoma. The other name is very simple. It is known as oat cell carcinoma. Small cell carcinoma, also known as oat cell carcinoma. Very good. Anna. Now tell me its diagram. What you can imagine? Close your eyes and imagine the diagram. You will say, ma'am, I can't see the cells are small. Okay, they are blue in color. Okay, the nucleus is there, but cytoplasm is very scanty. The cell borders are very ill defined. Anna. The nucleus is showing salt and pepper, and it is azopardy effect. The blood vessels are blue in lining, azopardy effect, and the necrosis is very high. So these all findings I have learned. You get many questions on that. Say yes. Instead of learning like a list, try to see all the findings in the diagram. है ना? Humans have a better pictographic memory. Our pictographic memory is much better. Pictographic memory as compared to our textual memory. है ना? If I show you the text, you will forget. But if I show you the pictures, there are chances you will retain it. So try to take the pictures, snapshot, not in your mobile. Take the snapshot in your mind. Just close your eyes and take a snapshot in your mind. है ना? So as soon as I say small cell carcinoma, you should imagine this diagram. As soon as I say squamous, you should imagine the keratin pulse. As soon as I say the adeno, you should imagine the four patterns. The lapidic is the most important among them. Hana, so just imagine that. Once you imagine the diagram, all the findings will come in your mind. Yes, this is a way to study pathology. Pathology is not like the text. No, I cross text and never learn text. I learn images. Pathology is all about images. Just see the images. Actually, images are talking with us. They are saying something. We have to understand the language, decoding. Everything is shown in the image. You can see the cells are small. You can see they are blue. You see there is no cytoplasm. Everything is shown. The only thing you depict it. You should decode it. Okay. This is a way you should study pathology overall advice. Okay. Now, small cell, few more points. It is the worst among the four. Squamous, adeno, small cell, and large cell. So worse among the four is small. Worse. Hardly even after treatment, the lifespan is 6 months. 6 months. So once person come to know that person is having small cell, even on taking the treatment, the person dies in 6 months. So it's very aggressive. Very high chances of metastasis. So mostly 99% time when the person come to know the person is having small cell carcinoma in the lung, it's already metastatic. 99%. So at the presentation only it's metastasis. Most common organ it metastasizes brain. Directly patient comes with lung with brain mets. Main tumor in the lung with the brain mets. Followed by adrenal. The second most common organ among the endocrine organ it's adrenal and brain. So most common organ metastasizes brain followed by adrenal. Metastasis very common, very poor prognosis. The lifespan is the 6 month. The lifespan is 6 months. Now, I am teaching you 4 types. Squamous, we have already seen. Adeno, already seen. Small cell I am teaching you right now. Iske baad only one is left, large cell. Now listen, among them, what is the treatment of all? You will say, ma'am, this and this. They are treated with surgery. These 3 are treated with surgery. Surgery followed by chemotherapy and radiotherapy. But main treatment is surgery. We do the debulking. First we take the tumor out and give chemo radio. But this one already metastatic now whenever present. So surgery is not the treatment of choice. These are chemo and radio. We treat them with chemo and radio and they respond drastically with chemo and radio. On giving chemo and radio, they just disappear. I mean, they just, melt. They are very responsive to chemotherapy and radiotherapy. The others are not very responsive. So I am saying 2 things contradictory. I am saying the small cell carcinoma are responding very highly to chemo and radio as compared to others. Still they are very aggressive. they respond very good. भाई response तो बहुत अच्छा है, फिर भी patient बच नहीं पाता because it is already metastatic, है ना? So it is highly sensitive to chemotherapy and radiotherapy among all the four, but still its prognosis is poor. You may be thinking, ma'am, if it's sensitive to chemo and radio, the prognosis should be good. No, on the contrary, the prognosis is poor. You got it? Huh? Everyone got it? So large one is, the last one is a large cell carcinoma. It occurs at the periphery, and as the name indicates, large cell, here the tumor cells are very large. Nothing important in that. The tumor cells are very large and giant cells are there. The tumor cells में giant cells. Giant cells are very common. So you can see the large cells with the prominent giant cells. That's it. That's it. How many of you got it? How many of you got it? Can we revise it quickly? Huh? Can we revise the 4 tumors quickly? I taught you squamous. I taught you adeno. I taught you small cell. The ultra important is small cell. And I taught you large cell. Very less important, large cell. Now you tell me among adeno and squamous first. Huh? So squamous is more common in India. This is most common in world. This is most common in smoker. This is most common in non-smoker. This is most common in females, males. This is most common in females. This apart. No? This story apart. Apart from that, tell me this thing, which is central and peripheral. You will say, ma'am, this one is central. This one is peripheral. Okay, this one is both central or peripheral, and this one is peripheral. So you have to learn this story also. Separately, you have to learn their location. Now tell me the histology of all of them. Here, main feature, the tumor cells are arranged in sheets. They are polygonal, and keratin is the hallmark. Keratin, pearl, whorl, and cytoplasm may be keratin. Keratin is the hallmark. Keratin, never forget. Okay, here we have 4 patterns. What are the 4 patterns? We have acinar, that is glandular. We have papillary pattern, in which finger-like projection. The most important is lapidic, also known as bronchoalveolar, and last one is compact. So question come on lapidic. 2 important findings. Number 1, it is having clara cell, and number 2, it goes to the opposite lung. That's it. Coming on the third one, small cell. Very important findings in the small cell. The tumor cells are small. Imagine the diagram. The tumor cells are small. They are blue. They have scanty cytoplasm. No cell borders. 2 unique findings. Kya hai? Salt and pepper. Salt and pepper, never forget. And Azzopardi. Azzopardi effect. You know what is Azzopardi effect? Never forget. 2 important findings. Apart from that, few other findings here which are important. It is having the worst prognosis among all. It is most aggressive among all. It metastasized to brain followed by adrenal. Lifespan is hardly 6 months, but it is chemosensitive and radiosensitive. So these are the additional findings you have to learn along from histology. Last one is large cell. Large cell, nothing important. The large cells are there. Tumor cells are large and giant cells are there. This is how I learn. One more thing before I forget. Let me tell you the main marker in all 4. You have to learn the main marker, one marker. If I'm just suppose you are sending a slide to me, or you are sending a specimen, you are a surgeon, oncosurgeon, and you are sending a tumor, lung cancer to me and calling me, ma'am, see which of them is it. I'm sending you a specimen of lung cancer of my patient I have resected. So I will see, okay, but I'm having the confusion. Before releasing the report, I want to become sure. So I can apply a special marker. Here the special marker is cytokeratin. Here also cytokeratin, but cytokeratin 7. Cytokeratin 7. Okay, or cytokeratin. In small cell, there are 2 markers. Chromogranin, you can write down, it's written in my notes also. Chromogranin and synaptophysin. Synaptophysin. Okay, and here we don't have any special marker. So say the special marker of all of them. Here it's cytokeratin, here also cytokeratin, here chromo and synapto. And here we don't have any. So there are many questions based on that. Please learn. See the marker is written here. Here. Synapto and chromo. Chromogranin and synaptophysin. Say people, yes, got it. I tried best to overview the 4 types of the lung cancer. Now coming on paraneoplastic syndrome. What is paraneoplastic syndrome? Listen. This is the lung. Okay, this is the lung. Okay, this is the blood vessel. So this is the lung tumor. There is a tumor in the lung. For example, this is a tumor. These are the tumor cells. So sometimes what happens now, the tumor cells secrete certain hormones or hormone-like things in the blood. Hormones. And these hormones produce the symptoms. The patient don't have symptom due to lung cancer. The patient have symptom due to the hormones secreted by the tumor cells in the blood. That is known as paraneoplastic syndrome. That is known as paraneoplastic syndrome. You got my point. What is paraneoplastic syndrome? The patient don't have cough. Patient don't have dyspnea, patient don't have symptoms of lung cancer, but patient is secreting the hormone in the blood. For example, patient is secreting ACTH, so patient come with Cushing syndrome. Cushing syndrome is due to ACTH. Patient is not coming with dyspnea, so it is paraneoplastic syndrome. How many of you got it? People respond. How many of you got it? Huh? So that is the thing. So these lung cancers secrete various types of hormones. You have to learn the sequence of the hormones. Learn squamous. We will start with squamous. Squamous cells secrete parath hormone in the blood, and that's why, because of the parath hormone, they can cause hypercalcemia and hypophosphatemia. See, parath hormone causes calcium absorption and phosphate excretion. So parath hormone cause hypercalcemia but hypophosphatemia. So it is seen in squamous carcinoma. And clubbing of fingers is also common. है ना? Clubbing of fingers, the fingers clubbing. So learn two things in the squamous: parath hormone and clubbing. Parath hormone and clubbing. After squamous, come on the adeno. We will see in the same sequence. Huh? Here I have changed the sequence. Don't change in your mind. You will get confused. In adeno, learn three things. Three things are paraneoplastic syndrome: hypertrophic pulmonary osteoarthropathy, hypertrophic pulmonary osteoarthropathy, lung and the joints are involved, DIC, and migratory thrombophlebitis. You have to learn a little bit. Coming on the third one, small cell. Small cell secrete two hormone, ADH and ACTH. ADH will lead to SIADH syndrome, and ACTH lead to Cushing syndrome. है ना? You have to learn that. And large cell will secrete the sex hormones. The sex hormone, I mean FSH and LH in the blood, that will lead to gynecomastia. So you have to learn. How we will learn, people? Please help me. Please help me, everyone. Who will help? Only few people are responding. Everyone. Mishti, would you like to respond? Paraneoplastic syndrome. You tell me paraneoplastic syndrome in various lung cancer. You tell me what are the presentation in squamous, what are the presentation in adeno, what is the presentation in small cell, and what is the presentation in large cell. Paraneoplastic you have to tell. You don't have to tell the main tumor. You have to tell me these tumors secrete hormone, and because of the hormone patient is having the symptom. So here we have two symptoms. Yes, what are the two symptoms in squamous? The first, it secretes parath hormone, PTH. है ना? PTH causes two things. So patient comes to us with hypercalcemia or hypophosphatemia, है ना, in squamous cell, or as patient comes with a clubbing of fingers. है ना? Clubbing of fingers, we don't know the reason, but clubbing of fingers is also common. So patient don't present with the symptoms of the squamous cancer, but the patient is coming to us with these two symptoms. So we can assume the patient is having squamous cell carcinoma. Coming on the adeno, in the adeno I told you three things. What were the three things? I told you thrombophlebitis, है ना? Thrombophlebitis. I told you DIC and pulmonary osteoarthropathy. Pulmonary osteoarthropathy. You have to learn that. Small cell में two hormones. I learned two hormones. What are the two hormones? I learned ADH and ACTH. Okay, ACTH is very simple. It will lead to Cushing syndrome. Okay, and ADH, antidiuretic hormone, secreted from the pituitary. So it will cause SIADH. Oh, what is SIADH? Okay, and large cell secrete FSH-LH. FSH and LH, that will lead to gynecomastia. You get many questions on paraneoplastic syndrome, people. Absolutely right, Mishti. Yes. So you have to learn which hormone in which. You have to learn which hormone in which cancer. So this is paraneoplastic syndrome we have learned. Okay, the last thing I must tell you something is Horner syndrome or Pancoast tumor. One and the same thing. Horner or Pancoast. Listen. This is the lung. Okay, these are the two lungs. Okay, I told you there are two type of tumors. Okay, just a second. This is the trachea and this is the bronchi. The tumor which occur at the periphery. Which one occur at the periphery? Especially adeno occur at the periphery. For example, this is a tumor occur at the periphery. For example, it's adenocarcinoma occurring at the periphery. So from the periphery, the tip of the tongue, I mean the superior tip of the tongue. The tumor is at the periphery, at the upper pole or the tip of the tongue. So basically from here we have you heard about the sympathetic nerve plexus? Sympathetic nerve plexus is passing. Sympathetic nerve plexus is passing from here. So because of the tumor, it get involved. And it will produce the symptoms. And it is known as Horner syndrome. It is also known as Pancoast tumor. Whenever the tumor is the apex of the lung, then only it occurs. Say what I told you. Whenever lung tumor is at the apex of the lung, it involves the sympathetic nerves. Many nerves are there. I will tell you which nerve is involved. and it will produce the symptom because of the nerve involvement. It is Horner syndrome. How many of you got it? So here the tumor, yes, absolutely right, Mishti. Here the tumors are presenting at the apex, apical tumors, है ना? They are usually adeno, because we know the squamous cell occur at the hilar region. Squamous don't occur at the periphery. Usually adeno occur at the periphery. So it can be others, but usually it's adeno, and they compress the sympathetic nerve plexus. So it will produce 5 symptoms in patient, है ना? The mnemonic is Punjabi meal, MEAL, Punjabi meal. P stand for ptosis. You know, the eyelid of the patient drops because of the nerve of that is compressed. The eyelid drops of one of the eye or both eye, है ना? The eyelid will drop, ptosis, upper eyelid. You know what is ptosis, है ना? And if you open the eye, you will see the pupil. In the pupil, we have 2 things, na? Meiosis, mydriasis. Meiosis is constriction of the pupil. Mydriasis is dilatation. So that the eyelid ka jo upper eyelid hai, that is falling, and after that the pupil is showing meiosis. So ptosis is there, meiosis is there, endophthalmos, the complete eye will go inside. Endophthalmos is there, hai na? So 3 things in the eye. Learn 3 things in the eye. Imagine an eye in which the eyelid falls. Imagine an eye in which the pupil is constricting, and imagine an eye which is going inside. So say the 3 things: ptosis, meiosis, endophthalmosis. So learn the 3 things. After that, no sweating on the body, even on heating. Whenever we feel hot, we have the sweating now in the hot weather. So there is no sweating, है ना? N यानी absent, hydrosis. Hydrosis मतलब sweating, no sweating. N hydrosis. The hydrosis is absent. Hydrosis is sweating. Such people never sweat. They never sweat now, है ना? And loss of ciliospinal reflex. Loss, L for ciliospinal reflex. So you can say Punjabi, MEAL, out of which the first 3 things are in the eye. Say yes. Say ma'am, ptosis, है ना? Meiosis, endophthalmosis. One is anhydrosis, that is sweating, and loss of ciliospinal reflex. This is Horner syndrome. All the things are due to the tumor at the apex of the lung, and this apex of the lung tumor is compressing the sympathetic nerve plexus. It is compressing or involving the sympathetic nerve plexus, that is leading to the 5 things. Say yes, people. Say yes. Okay, got it? So that is the thing. Now please, everyone on the screen, everyone, I am going to tell you something very important. You get many questions on that, and then we are going to solve the questions. We are done with lung cancers also. We will solve the questions after that. Okay, listen. I will give you a list. Hannah, most of it you already know. The thing you don't know, you have to note down. You tell me which is most common in India and world, you already know or don't know. Most common in world and India. I guess everyone know. I told you many times. In India, it's squamous. In the world, it's adeno. I guess you already know that. But how many of you know that which is more common in young patient? In young patient, adeno is more common. In young patient, adeno is more common. How many of you know which cavity is most common in the lung? Cavity. It formed cavity. So squamous maximum form the cavity. Squamous form the cavity maximum. Tell me the form which metastasize very frequently. The worst one. Small cell, we know that. है ना? Tell me the size which goes to the opposite lung. Right to left, left to right. So it is adenocarcinoma. Which variant? Adenocarcinoma का lapidic type. Lapidic type goes to the opposite lung. है ना? Clubbing is common. Oh, I'm sorry, least common. You can leave it. Gynecomastia seen in large cell. I already told you gynecomastia large cell. है ना? Most common to metastasize is brain, followed by adrenal. है ना? Organ. ठीक है? Worst prognosis is small cell. Most responsive to chemo is small cell. Most responsive to radio is small cell. है ना? Most common endocrine organ involved is adrenal. Brain followed by adrenal. है ना? Best prognosis is squamous. So tell me the 2 things. Worst prognosis, best prognosis. Huh? You will say, ma'am, worst is small cell and the best is squamous. Squamous is having best prognosis. Who are central? The central is squamous and small cell. Who is peripheral? The adeno and the large cell is peripheral. Cushing syndrome किसमें होता है? Cushing occurs in small cell. SIADH also occurs in small cell. Parathormone कौन release करता है? Causing hypercalcemia. Parathormone is secreted by squamous. So these all are your PYQs. You believe or you don't believe. You have to learn these one-liners. I have told you individually also whenever I taught you the 4 tumors. How many of you got it? And how many of you are ready for the questions? Huh? Are you ready for the questions? Give me a thumbs up and give me a minute to drink water. Huh? Ready? So this is the first question in front of you. Read the question, tell me the answer. Read the question, tell me the answer. Most common type of lung cancer. Tell me the most common type of lung cancer. I have not mentioned anything. I am asking overall. Overall means I am asking in the world. I have not mentioned anything means I mean in the world. Is it small cell? Is it adeno? Is it squamous, or is it large cell? Why you people are not responding? People quick. Yes. I am asking most common cancer in the world. Be fast. What is the most common cancer in the world? Yes, in the world the answer is adeno. But if I change in India, the answer will become squamous. The currently answer is adeno. The next question is in front of you. Commonest type of lung cancer in non-smoker. I am asking most common cancer in non-smoker. Non-smoker. Not in smoker, I am asking in non-smoker. So what is the most common cancer in non-smoker? Yes, the most common cancer in non-smoker is, of course, it's adeno. And if I change the question from non-smoker to smoker, answer will become squamous. Okay, so you know how the question will be changed. The next question, most common histological type of lung cancer in India. I already told you, in India. So in India, it's squamous. In India, it's squamous. Adeno is in the world. Okay, this one is in smoker. This one is in non-smoker. This one is in males. This one is in females. So you get 6 questions, 6 MCQs. Please learn it by heart. Please learn it by heart. Okay, yes, very good. The next question, which of the following lung cancer shows Clara cells which are used for the diagnosis? Clara cell, unique Clara cell. Is it squamous cell? Is it bronchoalveolar cancer, which is a type of adeno? Is it large cell, or is it papillary? Is it papillary? What is the correct answer? Yes, bronchoalveolar, also known as lapidic type. So I told you adenocarcinomas are 4 types. Okay, what are the patterns? It can be acinar, it can be papillary, it can be lapidic, it can be compact. So lapidic means 2 unique things we have learned. Number 1, it is having Clara cell, which is our question right now. And number 2, it can metastasize to opposite lung, right to left to right, very commonly. So that is the thing. So coming on the next question, a 56-year-old chronic smoker having a mass in the bronchus. Which marker would you like to do? Would you like to do cytokeratin, vimentin, epithelial membrane, cadherin, or leukocyte? Tell me the marker of the lung cancer. I told you markers separately. Now see, it is a clue given to you. The patient is a smoker. Smoker mein which is common? Say ma'am, smoker, squamous cell is common. One more clue. The tumor is at the bronchus. I mean it is central in location. Hana? So 2 clues are given to you. Smoker and central in location. The tumor is in smoker and the tumor is central in location, not peripheral. So I mean they are talking about squamous, not adeno, not small cell. They are talking about squamous. And in squamous, the marker is cytokeratin. I already told you. So correct answer is cytokeratin. This is how we approach. Yes, absolutely right. Okay, absolutely right. Okay, coming to the next question, which is the marker of small cell cancer in the lung? Tell me the marker of the small cell cancer. So I told you, is it chromogranin, cytokeratin, desmin, or vimentin? Small cell cancer. I told you 2 markers. Yes, it is chromogranin and synaptophysin. The synaptophysin and chromogranin are the 2 markers of the lung cancer, right? And if I change the question here, if I ask you squamous or adeno, the answer will be cytokeratin. For squamous and adeno, it's cytokeratin. You get questions on the markers. Coming on the next question, which of the following histological type of the lung cancer has the worst prognosis? The worst prognosis in the world. Which of the following type of histological cancer have the worst prognosis? Is it squamous, adeno, alveolar, or small cell carcinoma? Yes, you all are right. The correct answer is the small cell carcinoma. Okay, so here other options, desmin and vimentin, are the markers of the connective tissue, mesenchymal markers. These are known as mesenchymal markers. I mean they are positive in the muscles and bone tumors, but not here. Okay, these are the mesenchymal markers. Okay, Manish, got it? So yes, the correct answer here, the worst prognosis is the small cell. We all know small cell. Hardly the lifespan is 6 months after the diagnosis, even on treatment. The worst prognosis. The maximum metastasis. Maximum metastasis occurs in the brain, followed by adrenal. Okay, the next question. Chronic smoker develops cough, hemoptysis. There is a chronic smoker, imagine, and he is going to the doctor and he is having cough and hemoptysis. What is hemoptysis? Blood in sputum. While coughing, the patient is having blood in the sputum, that is hemoptysis. Doctor tells that he is having the most malignant type of lung cancer. So what does the doctor mean? The most malignant lung cancer. So doctor is telling the patient that you are having most malignant lung cancer. Is it squamous? Is it small cell? Is it large cell? Or is it adeno? The worst one. Yes, you all are right. The correct answer is B. The small cell is the worst one, the most malignant one. So the clue in the question is the most malignant. Most malignant one is small cell. The next question. Lung carcinoma metastasize most frequently to which organ? Is it brain, liver, adrenal or bone? Brain, liver, adrenal or bone? So no, it's not adrenal. The answer should be brain. Brain followed by adrenal. If brain is not given in the option, go with adrenal. Okay, so we are done with the lung cancers also. Till now, since morning, we have completed 3 cancers. What 3 cancers? We have already completed thyroid cancers. We have already completed Mann syndrome, and now we have completed lung cancers. Now, last I am going to take the renal tumors, the kidney tumors, the renal tumors in children as well as an adult. So, are you people with me? Can I start? Huh? So, before going to the next, let me tell you something. Nothing will feel you better except doing the work. So, what I have seen now, most of the students, when they don't study, just suppose for day 2 you are not studying, and after that you feel very demotivated, that I have not studied. You have guilt, or you feel very bad that I have wasted my time, and you try finding your happiness here and there. You look for the motivation, you look for motivational videos, you look this, that, but nothing will feel you better except work. Start studying. The day you start studying, you will feel happy. Now you have seen, you may have seen, if you set the targets for the whole week, for the whole month, whatever, you may be having your exam. I don't know in which phase you are preparing right now. Maybe your exam 1 month apart, 5 months apart, or next year, or after 2 years. Whatever exam you are targeting, there may be a target exam. You may have certain time frame for that. You may have scheduled your entire syllabus in that. So scheduling is very important. You have to stick on your schedule. So whenever, just suppose in my schedule today I have to study for 5 hours, or I have to study for 6 to 8 hours, and I study that day, I have completed that portion which is there in my schedule. I feel very happy or satisfied at the end of the day. You may have noticed that. It don't happen only to me, it happens to all the human. But if it is scheduled for 6 hours and you have studied 0 hour today, at the end of the day, you have done the entire day, you have enjoyed it, you have watched movie, you have wandered, but at the end of the day, you are unhappy. While sleeping, you are not satisfied. You will have something in your, in your mind that is not feeling good inside you. So unless until you don't work, you will not feel good. So start studying, start working, stick on your schedule. Anyways, let me come on the last tumor, tumors of the kidney. Can I come on the tumors of the kidney? Can I start? Okay. So let me start the last portion, tumors of the kidney. We have completed the first 3 portions. So tumors of the kidney. Let me start. There are many tumors in the kidney, the benign, the malignant. So in adult, the most common malignant is adenocarcinoma. So I will teach you adenocarcinoma in the malignant tumors. Okay, in the malignant tumors, I will teach you adenocarcinoma in adults and Wilms in children. I am not teaching you benign. I am teaching you malignant. I will teach you 2 malignant tumors. One in adult, it is known as RCC, renal cell carcinoma, and one in children, it is known as Wilms tumor. It is in children. So I am going to teach you 2 tumors. Let me start with adenocarcinoma of the kidney. Same headings I will teach you for adenocarcinoma, that is known as RCC. RCC is renal cell carcinoma, adenocarcinoma, one and the same thing. And same headings I will teach you for the Wilms also, and then we will have a comparative analysis of the both in the end. Let me start with adult. Most common adult tumor of the kidney is renal cell carcinoma, also known as adenocarcinoma. So first I will let you know the introduction, etiopathogenesis, in which I will tell you the name of the mutations which leads to the cancer, classification ultra important, then gross, microscopy, clinical features, spread and prognosis. So all the tumors we have to study under these headings only. Let's start with adenocarcinoma, the adult tumor of the kidney, also known as renal cell carcinoma, RCC, also known as Gravet's tumor. It is also known as Gravet's tumor. It is also known as hypernephroma. Hypernephroma is a misnomer. Hyper matlab above, nephroma matlab kidney. Actually these are the kidneys. RCC occur at the pole of the kidney. This is the pole of the kidney. Usually it occur on the upper pole. So initially in the previous era, people used to think that it is not a kidney tumor, it is a tumor of the adrenal gland. Because it is occurring at the upper pole. But later, that's why they named it hypernephroma. Hyper means above, nephroma means kidney, above the kidney. But it is a misnomer. It is not a hypernephroma. It is actually a tumor of the kidney itself. Okay, got my point? Okay, so the same thing is written, hypernephroma. Thank you, nomads. Thank you for your compliment. So hypernephroma is a misnomer. Okay, we use the term RCC. It is the most common malignant tumor of the kidney in adults. I told you most common, always learn the most common. Most common tumor of the lung, most common benign tumor of the lung, most common malignant tumor of the lung. I told you in children also, adults also. Here I am saying adenocarcinoma is the most common malignant tumor of the kidney in adults. It usually occurs in males, not in females. And the preponderance is more common in old age, 50 to 70. I told you thyroid cancer. Have I taught you today? I told you all the thyroid cancer are more common in female, except one, that is medullary one, in which male and female is equal to. Both of them are same. And now I am teaching you kidney cancers, renal cancers. Here I am telling you all four types are more common in males. So see, some tumors are common in females, some are common in males. So gender mentioned in the question is always important. You have to pick whether the patient is female or male. So usually in the clinical question they mention the gender, they mention the sex, they mention the age, and you just bypass it. I mean, you don't read it. I have seen the students, they just, what is their age, how does it matter? Oh my god, it matters. It matters what is the age. Some diseases are common in children, some in young, some in old. So age and gender always matter. Please take it in consideration. Coming on etiopathogenesis, the most important etiopathogenesis is the tobacco. Now some people smoke tobacco in the cigarettes and bidis, and some chew tobacco. So both, whether chewed or smoked, both increases the risk of kidney. Please understand, someone is chewing the tobacco, increasing the risk of renal cancer. Someone is smoking tobacco in the bidi, cigar, he is also or she is also increasing the risk of the renal cancer. So tobacco in both form, I mean, in the chewed form also, in the smoked form also. That is my point. Okay, got my point. I will share the notes with the team where you are watching it now. The same team will share you on the this YouTube link only. They will do the pin. They will pin the notes here only. Okay, Miss Shi, you will get the notes after the lecture here in the YouTube link itself. Okay. Now this is the tobacco. After that there are certain mutations that causes the renal cancer. I will tell you the mutation when I will teach you the tumor by tumor. Okay. Cystic disease of the kidney are also there. Exposure to the asbestos, obesity, estrogen therapy, analgesic nephropathy, and tuberous sclerosis. These are the minor risk factors. The most important risk factor is tobacco. Okay. Now coming on classification of RCC, we are having 4 RCC in our syllabus. I will teach you all 4. The first is the clear cell. Second is papillary. Now papillary I have taught you in thyroid cancer also. Remember papillary, orphan eye nuclei, yaad aaya, grooving, inclusion bodies, ground glass appearance. That was thyroid papillary. I told you papillary in lung also. One of the type of the adeno. Adenos are 4 type. Acinar, papillary, lapidic, and compact. One of them is papillary. And now I am teaching you RCC also papillary. So papillary carcinoma is present in all 3 tumors till now, wherever I have taught you. So second is papillary. Okay. Third is chromophobe. Chromophobe also known as oncocytic. And the last one is collecting duct. Collecting duct also known as Bellini duct. First learn the 4 names. What are the 4 types of RCC? Students even don't know the types of RCC. You tell me the 4 types of the thyroid tumor. You tell me the 4 types of the lung tumor. And you tell me the 4 types of the RCC. This is the third tumor I am teaching you today now. So all of them are 4 types. I have described all 4 types very well. Yes. So in the thyroid I taught you papillary, follicular, medullary, anaplastic. I asked you don't change the sequence, and we have done a comparative analysis between them. In the lung I taught you again 4 squamous, adeno, small cell and large cell. I guess everyone knows adeno is of further 4 type. One of them is papillary. Okay, yaad hai, one of them is lapidic. And now coming on the RCC, I am teaching you RCC right now. So in the RCC, what 4 types? We have clear cell. The first is clear cell, most common. Second is papillary. Okay. Third is chromophobe, also known as oncocytic. And the last one is collecting duct, also known as duct of Bellini. Collecting duct, also known as. So please, my point is that first learn the classification. The first step, if you don't know the classification, how many type of cancers each of them have, then learn the peculiarities of all of them, learn the gross of all of them, learn the microscopy of all of them. That is the only thing in oncology you have to do. Okay, this is a comparative analysis of the oncology. Now coming on the 4 types of RCC. Let's continue the 4 types. Learn the 4 names. Don't change the sequence. In the sequence I will teach you. Okay, so this table I will read in the end. The same table. The comparative analysis we will do. Let me explain 4 one by one. Then I will read this table for you in the end. So can I start? Can I start with the first one? Before starting the 4, let me tell you gross of all 4 together. Okay, this is the gross. You can see where is renal tumor. It usually occurs at the pole, usually at the upper pole. It's solitary, single, unilateral, one at a time. It is not bilateral. Rarely it is 10 to 15% is bilateral, but 85% time it's unilateral. Unilateral single, it's not multicentric. See this kidney, see this is tumor. See this is tumor, it is golden yellow color. Typically golden yellow color. And areas of hemorrhage and necrosis can be present. It is at the upper pole. This is a typical presentation. Now one by one I will teach you the microscopy of all four. Gross is same. Microscopy of the four one by one. Are you people with me? Can I start the microscopy of one by one, all four? So let's start with clear cell RCC. The first one. This is the most common among the four. 80% most common among the four. This one. It arises from PCT. You know nephron. What are the 5 parts of the nephron? What is the nephron? Nephron is the structural and functional unit of the kidney. Humans have a pair of kidney. I guess we all have a pair of kidney, the right kidney, the left kidney. Inside each kidney, 1 million nephrons are present, nearly. So each human nearly have 2 million of nephron. Nephron is the structural and functional unit of the kidney having 5 parts. In the nephron, we have glomerulus. We have proximal convoluted tubule, PCT. We have loop of Henle. We have distal convoluted tubule, that is DCT, and collecting tubules. So this is glomerulus, this is PCT, this is loop of Henle, this is DCT, and this is collecting duct. Okay, now I will teach you various tumors now one by one. First I am teaching you clear cell. Clear cell arise from here. Second I will teach you papillary. Papillary will arise from here, DCT. Then the other two I will teach you the last two. The last two, that is chromophobe and duct of Bellini. Duct of Bellini. They both will arise from the here collecting duct. Okay, both of them arise. So this is the arise. Hana? So please understand, you can make this nephron and highlight it. Which portion, from which portion, which renal tumor is arising. Okay, so clear cell RCC. It is the most common type of RCC. Among the four, most common is this one. It arises from PCT. Now this is the diagram. Why it is known as clear cell? First tell me the pattern. Always tell me the arrangement. Start with arrangement. What is the arrangement? It is a nest. Small nests are there. This is nest. These are all nesting pattern. Okay, small nests are there. Inside which I can see the tumor cell. So this is a tumor cell. Appreciate any of the tumor cell. Take any of the tumor cell. Now see, the tumor cell have a nucleus which is vesicular. It is not very compact, it's vesicular. And the cytoplasm is clear. I can't see color of the cytoplasm, neither pink nor blue. No color. Clear cytoplasm. That's why it is known as clear cell. That's why it is known as clear cell, because the cytoplasm is clear. So say the tumor cells are arranged in nesting pattern number 1. The tumor cells are arranged in nesting pattern, and the tumor cells are big and they have the nucleus. The nucleus is vesicular and I can see clear cytoplasm. What is the reason for the clear cytoplasm? The highlight point is clear cytoplasm, because the cytoplasm contain abundant of glycogen, and glycogen don't take the steam. Glycogen don't take. So because of the glycogen, the cytoplasm is clear. Please learn, it's clear cell carcinoma. And the gene which is mutated here is VHL gene present on the 3rd chromosome. This gene is deleted. That leads to clear cell carcinoma. So clear cell ka reason hai, how many chromosomes we have? This is human cell. Imagine this is a human cell. This is the nucleus. We have 46 chromosome, or else we have 23 pairs of chromosome. Okay, pair number 1, pair number 2, pair number 3, 4, likewise. I am interested in pair number 3. In the pair number 3, there is a gene on the P arm. There are two arms, P and Q. The name of the gene is VHL, von Hippel-Liniadoo gene, VHL gene. That gene is deleted, and that will lead to clear cell carcinoma. So please learn exactly. It's a very important MCQ. Please learn it. Okay. So that is the clear cell. What we have learned in the clear cell? Can you please tell me? Clear cell is the most common type. It's 70 to 80%. Pehli baat. VHL gene is mutated, है ना? Which is present on the 3P. VHL, von Hippel-Liniadoo gene. Okay, number 1. Others are also there, but don't learn it. Learn 3P. 3rd chromosome, P arm, VHL. 3rd chromosome ke P arm pe VHL is mutated. The tumor is golden yellow in color. The tumor cells are arranged in the nest, and they have a clear cytoplasm because of glycogen. They are arising from PCT. They are aggressive. And that's it. So these are the important findings we find. Now coming on the second, papillary type of RCC. Can I come on the second? Yes, absolutely right. Second is papillary. This is the second most common. See the percentage, it is 10 to 15%. That was, it is 75%. This is 10 to 15%. Second most common. It arises from DCT. That was arising from PCT, clear cell. This one is arising from DCT. Here the tumor cells are arranged in papilla. There the arrangement was nesting. Here the arrangement is papilla. So learn most common, second most common, PCT, DCT. There the arrangement was nesting. Here it is papilla. There the cells were clear. Here they are cuboidal. And here psammoma bodies are common. See, can you see the blue color? This blue color, appreciate karo, it is in concentric rings. The blue color is very small, but you can appreciate the concentric rings. It is psammoma. Now tell me, there are 4 type of thyroid tumor, and tell me there are 4 type of renal tumor. So thyroid में 4 type क्या थे? What were the 4 type? Papillary, follicular, medullary and anaplastic. And here the 4 types, what are the 4 types here? Clear cell, papillary, chromophobe, oncocytic and collecting duct of Bellini. So my point is that here also papillary and here also papillary have psammoma. I told you psammoma there also, psammoma, that is concentric calcification. Here also psammoma are present. So psammoma bodies are present in papillary carcinoma of both thyroid and renal. Thyroid and renal cancer. Say yes people, I am trying very hard to learn you. Okay, please learn it, please learn. You can appreciate psammoma bodies are there. Please learn. The highlight feature is the psammoma body. Learn this image. Okay. Now what is the mutation here? It is of 2 types, sporadic and hereditary. If it is hereditary, trisomy of chromosome number 7. And if it is sporadic, trisomy of 7 is there. Trisomy of 7 is common in both of them. But apart from that, 16, 17, trisomy is also there. Loss of Y is also there. And translocation between X and 1. I know there are many, but we can learn. I will help you. Okay. So clear cell and papillary. What is the mutation? In clear cell, we have only one mutation, the 3p gene deletion, that is VHL, von Hippel-Lindau gene deletion. That's it. Deletion, not trisomy. The deletion of this gene. That's it. We have learned only one. But here we have to learn something in the familial and something in the sporadic. It is of 2 types. Familial and sporadic. In familial, it is the trisomy of 7p. Okay. Here also trisomy of 7, 16 and 17. Okay. Trisomy of 7. Trisomy of 16. Apart from that, there is loss of Y and translocation between 1 and X. 1 and X. Am I right? Yes, 1 and X. So please learn it. Okay, so please learn. Okay. So what you are asking? Yes ma'am, but in adenocarcinoma, there is also papillary? No, no mystery. In the adenocarcinoma, you are asking for the lung, na? The variant of papillary adenocarcinoma of the lung. In the lung, there is no psammoma body. We have psammoma bodies in the thyroid and the kidney, but not in lung. Very good question, mystery. But in the lung, we don't have there psammoma bodies. It is not all the papillary have psammoma. That is my point. Psammoma of thyroid and psammoma of kidney. Papillary of thyroid and papillary of kidney have the psammoma body. It is not that all papillary of human body have the psammoma bodies. These 2 organs only. Okay. Okay. Let's move ahead. So what we have learned in the papillary? Please summarize. Papillary. We have learned its trisomy of the 7. Trisomy of 7 is the most common. It is in papilla. It's angioinvasive. It is multicentric and it arises from PCT. And it's 10 to 15%. Coming on the third one. The third one is the chromophobe. Chromophobe. It arises from collecting duct. The unique feature is that, can you see the tumor cells? What is the unique feature? Can you see something unique in that? Tumor cells are arranged in sheet, the first thing. They are arranged in sheet. If you see any of the tumor cell, it's like this. This is the cell, this is the nucleus, and where is the cytoplasm? Let me draw the cytoplasm. The cytoplasm is present at the periphery, like this. So around the nucleus, you are getting a halo. Can you see the around the nucleus? Around the nucleus, you are getting a clear halo. It is known as perinuclear halo. It is known as plant-like structure, perinuclear halo. Very unique feature. Learn perinuclear halo. So something unique present here is the perinuclear halo. That's it. And it arises from the collecting duct. And here, don't learn what is the mutation here. Don't learn the number of chromosomes, just learn hypoploidy or monosomy. It is not trisomy, monosomy. Loss of one. We have two copies of all the chromosome now. So one of the copy is lost. Either one of the copy of 1 is lost, 2, 6, 10, 13, 17, 21, Y. So learn hypoploidy word. Hypoploidy. Just learn hypoploidy of multiple this thing. Okay. Arun, papillary arises from PCT. Okay. Papillary arises from DCT. Clear cell arises from PCT. So let me draw the nephron for you. This is glomerulus, PCT, loop of Henle, DCT and collecting duct. So my point is that clear cell arises from this PCT and papillary arises from DCT. Okay. And the remaining 2 arises from here. That is chromophobe also and duct of Bellini also. Okay. Without any confusion, Arun, this is the answer. Please learn. Okay. Now coming on the 4th one and the last one. This one is having best prognosis. This one is having best prognosis. The third one, chromophobe. The last one is collecting duct or duct of Bellini. It is the least common type. It also arises from collecting duct. The unique feature, it don't have diagram. It is having abundant fibrotic stroma. The background have abundant of fibrotic stroma, which is known as desmoplasia. Desmoplasia is a feature here, which is having desmoplasia. Okay, it is having worse prognosis. So I am drawing the table. The same thing. I am drawing the table for you. So you can understand the 4 types. What are the 4 types of the renal cancer? We are done with the 4 types. What are the 4 types of the renal cancer? Can you tell me? The first one is the clear cell. The second is the papillary. The third is the, what is the third one? Chromophobe. Chromophobe, also known as oncocytic. Oncocytic. And the last one, chromophobe and oncocytic ke baad last one is your collecting duct, also known as duct of Bellini. ठीक है? So first tell me the percentage. This is the most common 75%. This is nearly 15%. This is nearly 4-5%. This is very rare. Rare of the rarest. है ना? Which is best? This is the best prognosis. Which is worse? This is having worse prognosis. है ना? You have to learn like this. ठीक है? Tell me from where they are arising. This is arising from PCT. This is arising from DCT. This is arising from collecting duct, collecting duct. Collecting duct, maybe this one is arising from cortical portion of the collecting duct, and this one is arising from the medullary portion of the collecting duct, to be very specific. To be very specific. After that, tell me the morphology, I mean the microscopy of each of them. Here in the microscopy, the important finding is that the tumor cells are arranged in nest. Okay, and they are very clear cytoplasm. The clear cytoplasm is due to high glycogen content. High glycogen content, you get questions on that. ठीक है? Here we have the tumor cells arranged in papillary pattern. They are arranged in multiple papillary pattern. The tumor cells are cuboidal in shape and they have psammoma bodies. The unique feature is psammoma. ठीक है? Here tumor cells are arranged in sheets and they have perinuclear halo. The plant-like perinuclear halo. Perinuclear halo is important here. Okay, and here last one, the tumor cells show background fibrosis. Background abundant of fibrosis, which is known as desmoplasia. So you get questions on that. If you are getting a question may glycogen or clear cytoplasm, they are asking for clear cell. If in the question you are getting psammoma bodies or papillary arrangement, they are asking for papillary. If they give you a perinuclear halo, they are talking about chromophobe. And if they give you a word desmoplasia, they will talk about the Bellini. Please learn. Now tell me last thing, mutation in each of them. Let me erase it. Tell me the mutation in each of them. We are done. I guess we are done. So tell me the mutation in all 4. Okay. So here mutation is in mutation of 3P gene. That is von Hippel-Lenido. Here we have trisomy. Trisomy of what? 7, 16, 17. Loss of Y and translocation of 1 and X. So this is here. This is here. Here I will learn the word hypoploidy. Hypoploidy and a monosomy of multiple chromosomes. I will not learn the number, but the important word is hypoploidy. And last one we don't know the mutation. No need to learn. I mean, okay, okay, yes. Perinuclear halos and chromophobe. Yes, yes. Okay. So can we go ahead? So you can see the same thing. So this is the most common type. Okay, VHL gene, clear cell mein VHL gene, clear cytoplasm. It arises from PCT. I told you all the important points which I mentioned here. Okay, so this is the table. Clinical feature of all 4, it's a triad. Patient come to you with blood and urine. Doctor, my urine is red in color. My urine is smoky in color. The gross hematuria, the urine become red and the patient run to the doctor. Urine become red in color because of gross hematuria. Flank pain in the lumbar region, flank pain and palpable abdominal mass. So learn the triad. The urine is red, flank pain and palpable abdominal mass. The triad. Spread, it spread. Via blood, it spread to the lung, and locally it can spread to liver and lungs. But via blood, it spread to the lung very commonly, the renal tumors. The 5-year survival is nearly 70%. Without treatment, the prognosis is very poor. With treatment, the 5-year survival is 70. With treatment, not without. Without treatment, the prognosis is poor. We are done with RCC. You want me to tell you the Wilms also? Finally, the Wilms is the tumor in the children. So we will continue the Wilms in the same heading and then we will compare the both. So Wilms tumor, it is also known as nephroblastoma. Okay, this is also known as, that was known as RCC, this is nephroblastoma. Okay, so here we don't have the types of the Wilms. Wilms occurs in children 1 to 6 years. And it is equal in male and female. The RCC was more common in male as compared to female. This is equal in male and female. The RCC was occurring 50 to 70 years of age. This occurs 1 to 6 years of age. So learn the age, learn the gender, learn the other name. Okay, it is the most common abdominal malignant tumor in the young children. Abdominal tumor. Most common tumor is leukemia in children, but most common abdominal solid tumor is this one. Okay, got it? Hana? It arises from the primitive cells in the kidney. It arises from the primitive cells in the kidney. Mutation, we have two mutation. WT1 gene present on chromosome number 11 or beta catenin pathway. One of the two mutation, you have to learn WT1 is more important. Grossly, we can't see the tumor. It is the entire kidney is replaced by tumor. I can't see the tumor. The entire kidney is replacing most of the kidney and shifting the normal kidney to the periphery. The normal kidney is shifted to the periphery and we see entirely its tumor. Imagine the gross there. We have a gross at the pole, the tumor at the pole. The entire kidney morphology is intact, but the tumor is at the pole. Here the entire kidney is replaced by the tumor. Hana? Microscopically we have only one type. We don't have further types, the four types. No. Hana? It's a triphasic tumor. Triple tumor. It is having three components. It's a triple tumor, triphasic. Blastemal, epithelial and mesenchymal. What is blastemal component? All these blue cells are the blast. Small round blue cell. One more tumor I told you, small round blue cell, the lung cancer. The lung cancer, small cell carcinoma of the lung cancer. It's looking same like lymphocyte. It's like the small blue colored lymphocyte. You can't see the cytoplasm. You can't see the cell border. And you can see small round blue cells. Small round blue cells. So small round blue anaplastic cells, these are the blast. Apart from that, I can see, what I can see? I can see the primitive tubules are there. The tubules. These are the tubules in the kidney, PCT, DCT. This is a glomerulus, which is not forming, it is aborting. So all them are destroying. This is epithelial component. This is epithelial component. The aborted tubules, glomerulus, this is epithelial component. And the background. Can you see the background? Pinkish something in the background. Let me show you. The background, the pink lining in the background, that is fibrosis. The background, see the lenient fibrosis. So that is mesenchymal component showing the fibrosis. It can be bone, fat, fibrosis, anything. So what are the three things shown in this tumor? See the red, green and yellow. The red one is the blastemal component. They are all blast. The green one is the epithelial component. Epithelial component is tubules and glomerulus, which are abortive. And the background is the mesenchymal component. It can be fibrosis, bone, it can be bone, fibrosis, fat. Got it? Clinical feature, it is usually palpated by the mother. The mother can feel something in the abdomen of the child. It's painless. It's palpable abdominal mass, painless, usually detected by the mother. Usually, that is a clinical feature. It also spread to lung via blood. Prognosis is very good, 90%, 5-year survival rate in the if the surgery and chemotherapy and radiotherapy, everything is given. 3 treatment. First do the surgery, followed by chemo and radio. Okay, so prognosis is very good. Can we compare the two and solve the questions? We are done. We are done. So tell me the other name of RCC. Say Gravid's tumor. And tell me the other name of the Wilms. Say it's hypernephroma, not hypernephroma. It is also known as Wilms tumor. So it is the Wilms tumor. Okay. Nephroblastoma. Yes, I was remembering nephroblastoma. It is also known as nephroblastoma. So other name. Tell me the gender. It is male more common in female. It is male equal to female. Here it is common in 50 to 70 years of age. And here it is common 1 to 6 years of age. So learn the age, learn the gender, learn the other name. Okay? So after the introduction, coming on etiopath. In the etiopath, most important etiopath here is the smoking. Not smoking, tobacco. Tobacco in the chewed form also and smoked form also. Here it is WT1 gene and beta catenin gene which is getting mutated. Okay, classification, here we have 4 types, but here we don't have any further type. Here we have 4 types. Clear cell, papillary. Okay, the third one is chromophobe, oncocytic, also known as collecting duct or Bellini. Here we don't have any types. Grossly, here it is present at upper pole of the kidney. Here it is replacing whole kidney. That is important, replacing whole kidney. Microscopically, here I told you 4 different microscopy. Here only one microscopy, triphasic. You know triphasic, blastemal component, epithelial component, mesenchymal component. Okay, clinical feature, here is a triad. Hematuria, flank pain and palpable mass. Here only palpable mass. No hematuria, no flank pain. This is painless. No blood, no pain. Only palpable mass detected by the mother. Spread, both of them spread to lung. This is also lung, this is also lung via blood. Prognosis here 5-year survival is 70%. Here 5-year survival is 95%. Okay, so you can see the prognosis also. We are done. How many of you got it? How many of you got it? So read the question, tell me the answer. Please, fast. Read the question, tell me the answer. Which of the following will have worse prognosis among the RCC? I told you which is best, which is worse. Huh? Is it clear cell, papillary, collecting duct or Bellini? Clear cell, papillary, collecting duct or Bellini is one, and the collecting duct or Bellini duct. So which of the following is having worse prognosis? Actually question is not very correct. Actually collecting duct or Bellini is same, na? Answer should be both. Hai Or else I have to change, third option should be chromophobe. Ideally third option should be chromophobe. Chromophobe is having the best and Bellini is the worst. You learn the summary. Clear cell, papillary, there is misprint in the question. Chromophobe and collecting duct, also known as Bellini. Collecting duct and Bellini is same. So this is having best, and this is having worse. So please learn the summary. Please learn the summary. Got it? Got it? Read the question, tell me the answer. There is a 40-year-old man presented with painless hematuria. Okay, take the clues. By manual examination revealed a ballotable mass in the right flank. In the flank. Flank is the lumbar region. Okay. So what I got it, there is a middle-aged man who is having the hematuria. And he went to the doctor for the examination. The physician is doing the palpation and he got a flank mass. Subsequently, right nephrectomy was done. The right kidney is removed. Maybe he is having mass in the kidney. And the mass is showing the cells of clear cytoplasm. So the tumor cells having clear cytoplasm. And areas of hemorrhage and necrosis are also present. Tell me the cytogenetic abnormality for this tumor. So first identify the diagnosis. My diagnosis is patient having hematuria, number 1, with a flank mass, number 2, and it is clearly given nephrectomy is done. So my diagnosis is RCC. Now we know there are 4 types of RCC, but the biggest clue given to me in the question is clear cell, clear cytoplasm. The cells with, so my diagnosis is straightforward. It's a clear cell RCC out of the 4. And clear cell RCC, we have mutation in chromosome number 3, von Hippel-Lenido gene. Yes, absolutely right. In this way we approach. So in the clinical question, you should have an approach, how step by step we are going. Don't jump on the answer. The correct answer is this. Because the diagnosis is clear cell RCC. That's why my answer is this. Okay. All of the following are true about RCC except. It invades renal vein. Yes. Hematuria may occur. Yes. It arises from PCT. Yes, some of them. Maybe the clear cell is arising from PCT. Yes. It is more common in female? No, never. It is always more common in males. So incorrect among them is D. This is how you approach. The next question. Chromophobe variant of RCC is associated with which mutation? Von Hippel-Lenido or trisomy of the 7 and 17, or 3p deletion, or monosomy of 1 and Y? I'm asking for the third one. I told you the abnormalities, cytogenic abnormalities of all 4. Clear cell, papillary, chromophobe, we will revise. Chromophobe and collecting duct. In clear cell, it's always von Hippel-Lenido present on the 3p deletion. In papillary, it's always trisomy. Trisomy 7, 16, 17, and there is loss of Y and translocation between 1 and X. Learn the 5. And here it's always monosomy. Hypoploidy or monosomy of multiple. And collecting duct we don't know. Now read the question. They are asking for what? They are asking for chromophobe, I guess. They are asking for chromophobe. For chromophobe it's monosomy. So my answer will be D. My answer will be D. How many of you got it? Answer is D. If I change the question from chromophobe to papillary, so answer is von Hippel-Lenido and 3p, one and the same. A and C dono ho jayega answer because the meaning is same. 3p only, 3p deletion is von Hippel-Lenido. And if I change the question, I change the question to clear cell. Clear cell, if I change the question, it is von Hippel-Lenido or 3p. And if I change the question to papillary, answer will become trisomy. Trisomy of 7 and 17. How many of you got it? So if I keep on changing the question, all the options can be changed one by one. Okay, this is how we go. Coming on the next question, most common variant of RCC. Which is most common among the 4? Which is most common? So of course, clear cell is the most common. Clear cell, and second most common is papillary. Okay. Histopathology showing large cell with plant-like perinuclear halo. Which of the RCC show perinuclear halo? Highlight the word perinuclear halo. Which of the RCC show perinuclear halo? Is it oncocytic, granular cell carcinoma, angiosarcoma or chromophobe? What is the answer, people? Yes, fast. Yes, tell me what is the answer. So perinuclear halo is seen in chromophobe. Okay, please learn. Oncocytic carcinoma arises from. Oncocytic is the other name of chromophobe. Oncocytic is the other name of chromophobe. So it is arising from collecting duct. It is arising from collecting duct. So finally, we are done with the 4 cancers today. I covered everything from pathology point of view, and in other subjects also, whatever is relevant I told you here. We completed thyroid tumor, we completed the Mann syndrome, we completed the lung cancer and kidney cancers. So that is the best I can cover today. Thank you so much. Thank you so much for being with me, having your patience, and thank you so much. If you have any doubt, please write down in the comment box. We will solve that. And if you want more lectures, kindly let us know. So the more sessions on oncology series are already planned. Anna, so the next session in this month only, we are having oncology part 4, episode 4, in which I am going to take entire hemato-oncology. In hemato-oncology, I am going to take everything about the leukemias and lymphomas in humans. All leukemias, all lymphomas. So basically, I will cover the 4 leukemias, Hannah, CML, CLL, AML, ALL, and I will cover the 2 lymphomas, Hodgkin's and non-Hodgkin's. So don't dare to miss that lecture. Try to attend it live. The session is scheduled on 20th of October this month. This month in the morning 9 a.m. onwards, we will continue. Hemato-oncology. After that, if you want more sessions on any other topic in pathology, let us know in the comment box and we will continue. Thank you so much. Bye-bye. Wishing you all the best. Study hard and stay blessed. Stay happy. Bye-bye.